Go ahead.
Morning. All right, it's 8 o'clock. Welcome. I apologize to those that have had difficulties online. We've fixed a few settings, so hopefully everyone online can join easily and listen in. We've got a few people here in the room in person. Thank you for joining us in person. And there's a few little treats because you're in person, I suppose. This is our 8th annual EMS Stroke and Heart Conference. Heart usually gets to go first, but that's purposely, we started the conference together, but I was bossy and put stroke in front of heart because heart always gets all the attention, don't you think? And the money too, by the way. So today, again, we have about 150 registered for online virtual. Our camera's right up there. We have Q&A that they can ask. And so our moderators over here will help us with any questions from the virtual audience. If you want to raise your hand, I'll let each speaker decide how they want to handle questions. There's going to be time at the end of every lecture for some interaction as well. So this is our agenda. Just a reminder, we are ANCC certified to provide nursing education, continuing nursing education. And we have also checked with OHA about for EMS personnel that this qualifies for your certification as well for licensure. You do have to attend the full conference. You do have to fill out an evaluation. And these people over here watching your eyes stay open. I can't help the virtual people. Bathrooms are out into my right side, your left side. Again, there's some beverages and a little fruits type stuff over on, again, your left side. Make sure you have signed in. If you're online, I really need you to, if your login doesn't say your full name, you need to tell us your full name in that Q&A session. And if you're in person, make sure you've signed in over here. Cell phones, as lovely as they all are, could you just make sure they're silenced? And if you have any good games to share with us, please let us know. And then I'm going to have Adrian come on over to the microphone.
Good morning. I got that part out. Good. Whew. Okay. So I'm Adrian Jones and I am the STEMI coordinator for Providence. And I manage all of the hospitals in the Oregon that come to St. Vincent's or Portland. So for my reflection, it is good morning. It's an honor to join you today as we focus on the critical role EMS plays in stroke and STEMI care. These are some of the most time-sensitive emergencies we treat, and the work you do, early recognition, rapid assessment, clear pre-notification, truly sets the entire chain of survival in motion. Every minute you save in the field directly changes outcomes in the hospital. Beyond the metrics, your presence, your calm, and your compassion shape a patient's experience from the very first moment. Today is about celebrating that partnership and the life-saving impact you make every day. And I get the honor to introduce Dr. Crispin Davies. He's one of the interventionists. And Dr. Davies brings expensive, whoops.
Very expensive.
I better put my glasses on. Brings extensive expertise in the percutaneous management of complex coronary disease and the treatment of ST elevation myocardial infarction. His training includes cardiology at the Royal Brompton National Heart and Lung Hospital and a fellowship in interventional cardiology at the University of Oxford. Before joining the Providence Heart Institute, Dr. Davies served on the faculty at Oregon Health and Science University, where he held leadership roles, including director of the Cardiac Catheterization Lab, Director of Interventional and Structural Cardiology, and Deputy Director of Cardiology at the VA Portland Healthcare System. And I get the honor to bring him up here, and I've been working with him for 6 years, and he is wonderful. So for you, Dr. Davies.
That's very kind. It's actually one of the funniest introductions. That was actually very, very funny. So funny. Hi, I'm Crispin Davies. Good to see you all. It's interesting because most people are virtual, which is great because if they don't like it, they can't throw stuff. Small in person is always good. So we're going to talk about ED STEMI cases. We're just going to look at 5 cases. We're going to talk about them. We're going to see what I learned in 2025 and what you might be able to learn. So we're going to look at 6 cases. We're going to talk about the ACC guidelines that came out in 2025. These are the tablets of stone that cardiologists practice by, and they were updated in 2025, and they provide the roadmap for what we do. And included in this is STEMI, because it's an acute coronary syndrome. I'm going to start with a reflection too, but it's a lot less good than Adrian's. I'm going to talk about Ernest Hemingway. And somebody once asked him, how did you go bankrupt? And he said, to begin with, very slowly, and then all of a sudden. So first case, this is December the 10th. It's the Alaska flight from Portland to Miami. 71-year-old man starts off the day. We've all done this. You've decided to take that early flight. When you book it, it says 7:30, you think that'll be fine, but then you don't really realize that means turning up at around 5:30, and then it means getting out of bed at about 4:45. And he did get out of bed and he had chest pain, but of course, you know, he decided it was good, decided to power through, got to PDX, parked the car, got through security, yay, got into the plane. It's a 737, so it's a single aisle plane, and he's halfway down in the middle seat when he codes. And an interesting story. He had bystander CPR, and bystander CPR in a plane in the middle seat absolutely sucks. It's just awful. I was not on the plane, in case you wonder, but somebody I know was, and they called me and they said, this is going really badly. He actually got 3 shocks and got ROSC. It's interesting that there are many things we can laugh about the US about, but one of the things it's absolutely great for is having defibrillators on planes. It's the world's best provision of defibrillation on planes, which I always think, yeah, but here's a good example of it, of maybe working. So he was transferred to PPMC in cardiogenic shock, and here is his 12 lead. Any thoughts about the 12 lead? Did they not tell you it was interactive? Oh, I'm so sorry. It was interactive, yeah. You signed up for this. Any thoughts on the 12 lead? And if you don't start talking, I'll just go on talking. Everywhere. I like that. It's sometimes easier, isn't it, to find the lead that's normal. But the thing that catches my eye is 2-3 in AVF. It's inferior. It's relatively straightforward. I can totally see V6, and I'll give V5 as well. The question is always whether it's inferior or inferior posterior, and people get very fussed about this, and people sometimes say, should we do posterior leads? And as an old person, what I was taught to do was take the 12 lead and turn it upside down, back to front, look through the light. It's a really great test, because then you've got exactly the same thing as if you'd rolled the patient on their front and done the EKG at the back, but you've done it in like 5 seconds. But here's the trouble. There are no longer any paper ECGs. So what do you do? Particularly, what do you do if you're a paramedic bouncing around, dodging the Portland potholes? You've got no paper EKG. So if you've got an iPhone, let's look at the audience. Who here has an iPhone? Okay, not bad. Who's a Droid person? Excellent. So if you have an iPhone, what you do is you take a picture of the EKG. Here it is. You then go into the photo settings and you press this button here once. You press this button here twice, and it goes from this to this. Let's look at the EKG manipulated like that. And here is the posterior EKG. If you look at this, you can see very clearly that there is ST elevation. And it's so, you might say, well, hold on, you already saw that. But it's so much more obvious if you actually see it. You realize that's not ST depression at all. That's clear posterior ST elevation. So for the Droid phone people, who were they? Yeah, I can't help you. But you know, the point about being a Droid phone user is that you feel a little bit different and you're a little bit of a rebel. And so this is just, you know, bought into that. So go with it. Okay, so this is the, so very clearly, this guy needs to go to the cath lab. We can talk about the guideline changes. And here's this angio. The right is fine. Here's the LAD. Here's the circ. I always think, what does a STEMI look like? It looks like someone took a pair of scissors and they just cut through the artery. This is not my patient. This is Dr. Catherine Dawson, one of my very skilled partners. There's the wire. There's the balloon. There is the circ. And this guy actually came off the table with a decent blood pressure, actually didn't need an impeller, and has now finished cardiac rehab. Whether he got to go to Miami, I've never found out. I always think, what a lot of drama for this stupid little artery. It's like, how could that be such a big deal? But it is, and he did very well. It's worth thinking about this population as a whole, which causes all such trouble. This is the 2024 report, which is the most recent from this large project looking at essentially trying to capture all the out-of-hospital cardiac arrests in the States. You can see that 42% of people receive bystander CPR. If you drill down into the data, you can see Oregon is one of the best states at 54%. It does better than average. Washington is one of the other ones that does very well. And you think of the culture in these states, and you think, yeah, that probably fits. We kind of like to help our neighbors. If anyone's ever actually gone into trouble in Oregon on the side of the road, it's amazing how many people actually stop you and offer help. It's something that's actually very heartwarming. If you look at people who survive this to leave hospital, about 10% do. That's a very small number. The only thing I can find to say feel good about this is, firstly, Oregon's actually higher at just under 14%, which is very good. Secondly, the vast majority of people, 8.2 of that 10.5, are actually neurologically intact. People always worry about long-term neurodisability, but it's a little bit less of a problem than you think. A very bad problem, but not as bad as you might necessarily think. So I think that's a good example of how teamwork, bystander CPR can really get great results. Let's look at the ACC guidelines for 2025. This is always a very fraught subject. Who with an out-of-hospital cardiac arrest should go to the cath lab? You've got somebody in desperate straits. Paramedics have put a colossal amount of work in. The EDs put a colossal amount of work in. There's a lot of pressure to fix it all in the cath lab. But it turns out that since most deaths are neurological, fixing people in the cath lab isn't necessarily going to alter outcomes. We're much clearer about this than we used to. Here are the guidelines. The way the guidelines work, green means go for it. Yellow, orange means like maybe, and red means don't touch it. So people who have had out-of-hospital cardiac arrest, they've got ROSC, and they're awake with a STEMI pattern on their EKG, or they have a reasonably good neurological prognosis, should absolutely go to the cath lab. If you don't have ST elevation, you do not want to go to the cath lab. You will not alter the outcome. There may be many other things going on. So what do we learn from that first case? Things, when they go good, go just great. It is worth checking for posterior STEMI, and you can certainly do it on your phone. Any other thoughts about that case? Again, it's the interactive session. But you get a pass because the lady over here actually already answered. Go for it.
Slightly related, but we're talking about airlines. I recently read an article where they're trying to push airlines to carry more extensive equipment, not just AEDs, but other resuscitation equipment. Are you or any other organizations helping to advocate that for the airline industry?
No, no, but I think it's an important thing. I always fear this is an interesting case because it shows how, when you first think about it, a defibrillator on an airplane is going to land you in nothing but trouble because you're going to be 30,000 feet. But you forget, and actually everyone here knows, so much of the flight is spent taxiing on the ground, and actually it is more useful than you think. For anybody who ever gets into this tangle on an airplane, it's worth knowing that there are centers manned by people who do this for a living, and you can always, if you get roped in as a healthcare provider, I always personally travel as an anthropologist, And not a healthcare provider, this is not an issue for me. But if you as healthcare providers were tempted to get into this, then what you do is you see the patient, you go and talk to the pilot, and they go to a center where they specifically do this for a living, and they will help you make that very difficult decision about what you do, whether you land the plane, etc. That would be my tip about that. Okay, next case. This is a 62-year-old. He presented with multiple episodes of VF at hospital cardiac arrest, eventually achieved ROSC, comes to an ED, and the upper one is his EKG. Obviously, widespread ST changes. I look at that, and V2 could be a posterior STEMI. V4, maybe. That would be an unusual pattern for a posterior STEMI. It doesn't really fit. You don't usually get posterior changes as far across as V4, and there's no real evidence of an inferior STEMI. Most posteriors actually are part of an inferior for obvious reasons. So I look at that and I don't find it super convincing. And one of the things I do is, if that's the case, I just repeat it about 10 minutes later. 10 minutes is not the end of the world. And repeating the EKG, particularly if there's been a lot of shocks, can be worthwhile, because you can get ST elevations, ST changes just from getting a lot of shocks. So 10 minutes later, you can see the EKG is very much settled down and looks a lot less convincing. So he would totally come under the class 3 indication, which means don't do it. This guy has got potentially a poor neuro outcome, and he's not got evidence of a STEMI. What has he got? This is a CT scan. This is a non-con CT scan. So that white stuff in here is subarachnoid hemorrhage. And it's an incredibly depressing CT scan. So he reminds me that even if you present with VF, a significant proportion of people actually have neuro events, and they will do very, very poorly whatever you do. And this is one reason why taking everyone to the cath lab doesn't work. Primary neuro is difficult to spot, but it's commoner than you think, and less than 3% survive. Case 3. This is a 73-year-old woman, 75. She comes from Palm Springs, and she's come for a holiday cookie baking party. That was the Monday before Christmas. She's flown in. The holiday cookie baking party is a big thing in her family. She bakes the cookies on Tuesday with her grandchild, during which she's getting really bad GERD just looking at the cookies. And then she turns up 2 days later with this EKG in the St. Vincent's ED in cardiogenic shock. Again, to use the analogy used by the lady over there, there's ST elevation everywhere. It really would be much easier to say where there wasn't. I don't think it's a single lead that is in any way normal. And she's in atrial fibrillation, and she's got a blood pressure of 90 despite neo support. DC cardioversion put her back in sinus rhythm, but didn't really alter that at all. And the question is, what do you do with this problem? Essentially presenting in cardiogenic shock. And the answer is you put an impeller in. You put an impeller in before you do anything else, before you even think. Do not think that patients with anterior STEMIs will do better when you open the artery. There's always this hope for me that, sometimes you open the artery, it's like magic, and it just like all gets better. It's like all those sort of things, in life where suddenly you're forgiven and it's all okay. But that will not happen in an anterior STEMI. If you open an anterior STEMI in cardiogenic shock, they will get worse, not better. And one needs to accept that up front. One needs to put the impeller in as the first port of call. I'm sure the impeller doesn't need any introduction in this audience. So there's the impeller going in. There's their coronary angiogram. You can see that there's the guide, there's the circ, and then it looks like somebody just cut the LED off with scissors. Here's the LED opened up, but it's not a particularly pleasant looking vessel. It's kind of thin and scrawny, and the muscle it's feeding here is well and truly dead by this point. you can reperfuse it, but to actually get a successful result in STEMI, you need to open the artery, which you can see. You need to perfuse the microvasculature, which you can't do, and then you need to reverse the ST elevation. And if you just open the artery, it doesn't do a lot of good. So let's look at the changes in the guidelines from the ACC. And this is a big change. For the first time, they recommend using an impeller, and that is because of data that came out in 24, which showed that impellers truly save lives in cardiogenic shock. You might think that was self-evident, but it has taken a long time to prove, and there have been many negative trials with other things. So it says in selected patients with STEMI, insertion of you can't say that, then impeller is a reasonable option. I totally agree. Always put it first with an anterior STEMI. The unpleasant lesson we've learned is that the impeller you put through the legs for the femoral gives you 3.5 liters a minute. That should be enough, but it turns out not to be. If you truly need an impeller, that will get you overnight. Next morning, you're going to have a surgeon to put a impeller, a 5-liter impeller in the axillary artery. And the impeller we use in the cath lab is merely a stopgap to that. Late presentation still has a very poor prognosis. I'm sorry to tell you, this lady did not do very well, even with an impeller, and died within about 24 hours. Here's the big question. The big question is, should all anterior MIs have an impeller before you actually open the artery? It's very clear from what I say that people in cardiogenic shock, absolutely, impeller before artery. But what's not certain is whether all anterior MIs should actually have an impeller first. You think I've totally lost it, don't you? I think that idea that the idea that you wouldn't touch the artery, you'd leave it alone while you put the impeller in, is like somebody saying something like completely weird and challenging. But actually, that is the big question. And in late March this year in New Orleans, the results of what's called the Unload trial are being presented. And this center was part of the preliminary research for that. And that's exactly what it is. It's patients who come to a hospital with an anterior STEMI, and half of it get immediate PCI, the other half get an impeller put in, and then you wait. Bizarrely, you wait with that blocked artery with the impeller in, and then when it's kind of had a chance to settle in, you open the artery. And that is the most challenging study which is going to come out this year. I have no idea. You think I'm going to tell you the answer? Nobody knows the answer yet. I can tell you that if it's positive, it will change all of our worlds forever, because it will mean a radical change in STEMI care. If it's negative, well, at least we crossed that one off the list. I have no idea which way it's going to go, but that's the sort of next big thing. By the way, just in case, are there any balloon pump fanatics in the audience? Anyone online? I mean, online you could admit it. The audience here is like no one. Any online balloonatics left?
Lunatics.
I'm sure there are, but they're just kind of keeping quiet. We just have to admit it. Father Christmas, Santa Claus does not exist. Number one, and number two, the balloon pump does not work. It really does not work. There have been multiple studies showing that it does not work. It is a placebo intervention, if ever there was, with a lot of complications. Why do people keep celebrating Santa Claus? Because I would say to my children, if Santa Claus is real, how come we didn't stop off on Africa on the way and actually give those kids some water before they gave you all those presents? I don't think so, guys. Oh, sorry, should I have said that? That may have been a bit too much. There's a reason I got Worst Daddy in Portland award like 10 years in a row. But same idea, it just doesn't work. We have these ideas from the past and we cling on to them, and it often is really hard to, it's like pulling a stuffy from a child's arms to try to get over it. But it doesn't work, nor does ECMO. ECMO is a bigger surprise for me. I thought ECMO, with all its magic, was going to be good in STEMI, but it's not. You have to think about it from the point of view of the heart. From the point of view of the heart, when you're on ECMO, you've got this lovely blood pressure and it's so reassuring. But think of the heart, think of the left ventricle. Every time it squeezes, it's pumping into the aorta. And what does it meet? It meets the pressure from the ECMO going against it. So that blood pressure is actually fighting the left ventricle. If you're a cardiac surgeon, then of course you turn off the ventricle while you're operating. But for all of us who don't get that privilege, it's giving the left ventricle a really bad time. So ECMO looks good, but it really isn't. The balloon pump didn't even look good. And the noise is good. We've often wondered about trying to make some money on a little device that went boop, 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 and it would sort of make people feel that the balloon pump was there, and then they'd take them to surgery maybe without any of the trauma of doing it. So the guidelines are very clear. It gives a class 3 no benefit for balloon pumps and ECMOs. It gives a class 2A, much debated, for an impeller. We will have to wait for March to see whether our whole world changes and upfront impeller becomes the norm. Okay, so who wants to talk about that? Any questions about those views on impeller, ECMO, and the balloon pump? I haven't mean that negative. Of course, no one's going to say, yeah, I really like the balloon pump.
So let me ask, so this is specific, don't use a balloon pump in ACS cardiogenic shock.
Yes.
Is there, but there's got to be some other non-ACS cardiogenic shock? Speaking from a brain person.
Yes, I think that's a really good question. And my view of life is very focused and limited, and I accept that. I think there are still some surgeons who like a balloon pump preoperatively. And since I'm not a surgeon and I live completely in awe of them and what they do, if they want a balloon pump if my child actually wants a stuffy, you think I'm really mean, but if they really want a stuffy, I'm actually not going to rip it from their fingers and throw it away. Similarly with the surgeons, if they want a balloon pump, then yeah, I'll go with it. No, why not? Whatever they want us to, give them the tools to do what they do, it's good. But if you actually look at the data for whether balloon pumps help surgery, there is actually a single publication it was an abstract at a meeting. It was never published as a paper, and the guy who presented it has disappeared, never been found since. The data is really not that good. So I think if you're going to make a hole in the leg that is at least 8 French, go the whole way, put a balloon pump in. Don't put a balloon pump in, put an impeller in. It's either impeller or go home. Obviously, ECMO has huge benefits in many, many places, which are not to do with STEMI cardiogenic shock. ECMO is a transformational treatment. We should be using more of it. It's just that if you have a primary problem with your heart, you need to add an impeller as well. You need EC power because you need to offload that ventricle. You need to, give it some chance of reperfusing. Any other questions? Any big ECMO fans? There are ECMO fans out there. In Minneapolis, they have ECMO on for paramedics in a mobile ECMO van, and they drive around. The outskirts of Minneapolis, going to things like STEMIs, and they put you on ECMO in the back of the ambulance. Whether or not that's a good idea is very controversial. There are large-scale research which suggests that it might not work as well as they think it does. In other words, there's no question with the Minneapolis people that they have wonderful results. That's not in question. The question is, could it be more generalized? And to the present date, no one's been able to generalize it. And so until we can actually prove outside Minneapolis that it works, I don't think anyone's going to do it. Cardiogenic shock. So this is case 4, late presentation of an infra-posterior STEMI. I won't do it for you, but now that you know what to look for, you can see that there's clearly ST elevation in 3 and AVF, and then clearly a reciprocal. It's reciprocal. There it is. There's it flipped by the magic trick with the iPhone. Sorry, Droid guys, still can't help you. But then there you go. Oh. Is that laughing from a Droid person over there? Well, you can always tell the Droid people, can't you? Because when when you text them, there's that different thing that comes up. It's like yeah, of course. And you always know they're going to be there. So this lady presented, and you can see her coronary angiogram. You can see that she has the LAD here, which looks scrawny and unpleasant, diffusely diseased. You can see that she's in heart block because we've had to put a pacemaker in. You can see the circ isn't there, an absence of circ. There's the circ opening up. And there's the impeller, because she did not improve. In other words, this is the game plan for inferior cardiogenic shock. This is that you open the artery first, and then if they fail to magically turn around, which most do actually, then you can put an impeller in. That's the rule. Cardiogenic shock, inferior STEMI, try opening the artery first. Mostly, it actually works out quite well for you. Sometimes, as we all know, there's an unpleasant storm. But, you know, if you just sit tight, the storm will go away. Just drive through it. Atropine, dopamine, bit of patience. The guy who invented coronary angioplasty is a Swiss guy called Andreas Grunzig. And he said many sensible things. One thing, it could be simply awful or awfully simple. Very true. The second one was that one of the big skills of an interventionist was have the social skills to keep the lab happy while they sorted stuff out. And that they could tell stories, they could engage the lab. And this is a good time. During an inferior STEMI reperfusion storm, you want to be able to keep the lab happy that you've got this under control, it's all going to be okay. And by the time that people have, you know, stopped leaving you, usually the storm clouds have gone away. Heart block usually resolves when you open the artery for an inferior STEMI. So what do the guidelines have to say? We talked about 8.2. Big question is, do you need to fix everything? If you have cardiogenic shock and a patient with a STEMI, do you need to fix everything, or can you just fix the culprit? One of the ways I would look at it is if they had a STEMI at 9 a.m., at 8:30 in the morning, they were actually fine with those two other blocked vessels. What changed? It was that one vessel. And so the US guidelines very strongly think that you don't need to fix all of the arteries. This woman's LAD is really unpleasant. I'm not in any way doubting that, but you don't necessarily need to fix that in the middle of the night. You can just open the artery, put the impeller in, and let it all settle down. And that is very, very strongly the US view on this. Just fix the culprit, the rest of it. If they survive, you can fix it down the road. If they don't, you haven't really lost anything. Interestingly, in Europe, that's different. Europe look at exactly the same data set, slightly differently, and they fix everything. I have no idea which is right, but the US paradigm is just the culprit.
Dr. Davis,
Yeah.
doesn't it seem that that would help with the outcomes if you fix the other stuff going on?
Yeah. It doesn't seem to. In the only trial ever done of this, it actually didn't. They did worse. And one of the things I look at, I mean, this LAD is horrible. I can totally see that. But it actually has flow down it. You don't need great flow. And as we all know, when you know, the enemy of good is better. And once you start fiddling, it often unravels. And it is at least open. If you fiddle with it, it may block completely. So I'm actually a big believer in, particularly if you've got an impeller, actually, because the impeller is going to really improve the flow down there. It's very, very dramatic. I think you're safer off with the impeller and not fixing it, even though it looks icky. I give this example. There's a particularly horrid LAD, and everyone's like, you've got to fix that. But often, sure, if it was some critical 99% narrowing, sure, go for it. But it never is it? It's always a complete mess. And it may turn out to be completely occluded. So now I'm a believer in the US paradigm. Any other questions? Any other questions online?
Symptoms or
Yeah.
before you take them to the cath lab?
Do you mean why is it that people come late?
Why do you wait before you take them to the cath lab? Because it's been longer than 12 hours, and so you think there's going to be more issues, or it's because their troponins over 10,000 and you
Yeah.
already had the damage and you're not going to be able to fix it, or it's not going to change what's happening in the long run, I guess is what I'm trying to say.
I think one of the troubles I have in giving talks in my home institution is that there are people in the audience who see me really mess this decision up. By definition, I don't know who you are, because it's very hard to recognize everybody without their work clothes on. And so the data about this, there are two things I have to say about this. One is psychological, and I'm going to defend the middle-aged guy. For obvious reasons. Sorry, the people at home can't see me. I'm an incredibly youthful 30-year-old guy with beautiful head of hair. But for those in the audience, you can see I'm the middle-aged guy and I've got skin in this game. So what does midlife teach you? It teaches you that in life, most of the things that bother you actually go away. And if you power through them, then that's usually the way. If you spend a lot of time chasing a lot of ailments, it tends not to work out very well. And that's what you learn in midlife. And then they do it when they've got an anterior STEMI and it doesn't work out very well for them. And everyone's horribly mean to them. They say, why didn't you know? Didn't you realize? And they're like, yeah. And so I think we actually are mean to people when they have to run this gauntlet of all these people saying, no, the face plant emoji, why didn't you realize? And it's probably not very helpful. And it particularly isn't helpful in the instant. And it particularly isn't helpful when the wife, and it usually is the wife, sorry about the gender stereotyping here, starts going after said person for their failed decisions. So that's my psychological part of it. I think it's very hard to know when STEMIs start. They're often intermittent, and that really fools people. I've had friends who are cardiologists who had actually experienced these things, and they said it wasn't exactly like they expected it to be. The old-fashioned data is that if you didn't open the artery, well, the animal data is if you don't open the artery within the first literally hour, it's useless. But that turns out to be because they're literally tying off the dog artery with a bit of silk suture, and it's not very reproducible. The thrombolysis data, I'm never using that word again, not in this lecture. I really dislike thrombolysis. But the thrombolysis data basically goes off after about 6 hours. That's because thrombolysis sucks. We all know that. It's better than nothing, but it sucks. And then the PCI data actually used to be thought to be about 12 hours, but there's quite good data that 24 hours you can open people. So I tend to believe, and I should call out Mike Wilson. Mike Wilson directed the STEMI service here for well over 2 decades. And Mike has taught me a lot about STEMIs, more than I should have had to learn. And he taught me to be more permissive with it, and that actually you'd get good results. And so because it's so complicated, I believe that we should try to open the arteries. We should be permissive about it. We should go for it. It's surprising how often the results are better than you think. And then you go back and you take a more detailed history, because in the crisis of a STEMI, you never really get a very good history. So I would say open the artery first, ask questions later. With cardiogenic shock, there's good data that you could probably open the artery right out to 48 hours, but you're often not sure about it. I'll show you some more cases where it doesn't necessarily work out well. Does that answer the question? Rambling through the way. Excellent. It's my theme of the morning, late presentation anterior MI with cardiogenic shock. There's a very nice woman who is a social worker. Her husband left on a hiking holiday, out of cell phone range. I think the absence of the partner meant that she didn't get to bounce her symptoms off somebody else, and she presented very late. You can see that she has deep Q waves all over her anterior precordium. Another one of those EKGs which is abnormal everywhere, and she's in cardiogenic shock. Again, follow my rule. If you present like this, Impala first before you do the coronaries. You can see her LAD is completely shorn off. Here is her echo. She has a VSD. VSD is very perplexing to us. There's a sort of fantasy world which exists in textbooks. It's really interesting. As you get older, textbooks are getting out of fashion. But if you look at them, you realize that the textbooks which you look at now are very similar to the ones when you trained, even though that was quite a few years ago. They have a new shiny cover, but actually the innards of it are really very old. And in these old textbooks, then mechanical complications of STEMI seem to do okay. The reality is they do dreadfully. They do so badly. It is unbelievably how badly they do. And people with VSDs, people with mitral valve rupture, people with rupture of the free wall do exceptionally badly. And people who are just starting out in the field because they've read the textbooks or they've taken the exams tend to believe that these things are salvageable. They really are not, is the honest truth. Occasionally you can find somebody who's been salvaged, but it's increasingly rare to see it. So what do the new guidelines say? They say in patients with mechanical complications of ACS, short-term mechanical circulatory support can be useful. That is actually true. You can stabilize these people. That at least gives everybody time to think about it, decide what you want to do, maybe get the family around. I think a lot of what we do is actually giving families time to process this awful thing that's happened to their loved one. And that isn't such a bad thing. It's very expensive, I accept that, but that can be a useful thing. So putting an impeller in can be very useful, but please don't think that the next slide is going to say, and she went home, we fixed this percutaneously. It doesn't really happen. Sorry to be so negative. Has anyone had a good experience with mechanical complication of STEMI they would like to share with us and prove me wrong? And the STEMI coordinator in the corner there says, yeah, so sorry. It really ends very, very poorly. It's hard. One of the things that catches you out with this is that, particularly in somebody, as you probably know, but what is it, 2%, 3% of all STEMIs are silent, but 20% of diabetic STEMIs are silent because they've got a peripheral neuropathy. And so what often happens is the original STEMI pain is silent. They just feel unwell. And then they present with pericarditis about 4 or 5 days later with a big transmural infarct. And there's a differential between the neuropathy between the autonomic nerves, which give them that first STEMI pain you're all aware of, and the somatic nerves, which give them the pericarditic pain. And so they present with chest pain and a STEMI, but actually it's not the pain of the STEMI. They're experiencing a pericarditic pain. That muscle is truly dead, and often that they have a complication. And people are very confused. They say, well, hold on, I thought you got the mechanical complications 5 to 7 days later, not at the time. And it's because they've got the wrong pain. That's the other thing. You realize that biology doesn't read the textbooks. There is a small number of people who truly get, particularly women, particularly hypertensive women, they get the rupture, the VSD, within 24 hours. And that always causes some consternation, particularly if they're given thrombolysis. I said the word twice. It's really bad. Thrombolysis is not as bad as they make it out to be, but it does produce an early crop of mechanical complications in the literature, and you totally see that. Luckily, we live in a state which, by and large, is accessible by helicopter. It's amazing how infrequently one needs to give thrombolysis, actually. Sure, sometimes on the coast, the weather's bad, etc. But if you give a lot of thrombolysis, if I gave this talk in a more rural area, you would see an early crop of mechanical complications with thrombolysis. So I'm still waiting for the person to tell me they had a good result with this. I'm so sorry. It's so bad. Okay, case 6. I'm looking for time. A non-STEMI where the pain doesn't go away. This is a difficult area. This is a person who has a very classical history of what sounds to be like a STEMI, but it doesn't seem to be. And the EKG looks to me to be pretty normal. I'm not going to turn this over to the audience because, knowing my luck, somebody will actually look at the EKG, see something I've missed, and make you look foolish. Here's the angiogram. Here's the left coronary system. You can see a LAD there. You can see the circumflex tracking there. And there's like a hole here. There should be an artery there, and it's not. And there's no supply in here. Because what you see when you look at it is that there's a missing vessel here. Here's the wire. Here's the stent. And you can see that actually there was a STEMI. So here's the big question. We're all at a STEMI conference, but what is a STEMI? That sounds so weird. Of course, we all know what a STEMI is. But we tend to think of a STEMI as being ST elevation, but it isn't. It's actually complete occlusion of the artery. That's what a STEMI is. A non-STEMI is subtotal partial occlusion of it. But a STEMI is complete occlusion of one of those vessels, which on the surface produces ST elevation. But it's not the same for the 3 territories. If you block off your prox LAD, 90% of people get ST elevation. You block off your circ, 45% of people do. It's because it's around here. We don't put leads around here. And in case you want to try it, you'll find the lung gets in the way. It doesn't work very well. So some people you think they have an NSTEMI, but they've really got a STEMI. I know it's slightly sort of upsetting, isn't it? But there you go. As I told you, Santa Claus doesn't exist. And this is called the OMI paradigm. This is an idea that we should be rethinking this from STEMI, NSTEMI into whether it's an occlusive myocardial infarction. This is giving you nice pictures of what I told you. STEMI completely blocks the artery, and NSTEMI gives you partial occlusion. So the question is, are we missing people in the population we see who really have a STEMI, but we're missing it? And we should be activating our STEMI protocol. And should we be thinking more in terms of OMI rather than STEMI? So the reason I bring this up, in the ED world, this is very popular. And certainly if you see somebody with an EKG that is not particularly interesting and they have ongoing pain and it won't settle, because most NSTEMIs, they have pain, they come in, and then it settles. And we've really never been able to show that running to the cath lab sooner rather than later makes a difference, thankfully. But this, it makes a difference. And the advances, the people who want you to buy into the OMI paradigm would like us to try and identify these people with increasingly sophisticated EKG metrics and AI tools that they turn out to have some interest in, let's say, and pushing these people towards a STEMI world. And I think that's very interesting. I think if you see this type of patient, totally worth going to the cath lab early. The trouble is the NSTEMI population as a whole is very diverse. The nice thing about a STEMI, it's a STEMI. The trouble about NSTEMI is there's a lot of other stuff in there. A lot of people with type 2 NSTEMIs, with GI bleeds, with sepsis, etc. There's a lot of downside from rushing people to the cath lab. You come out ahead on a STEMI, but not necessarily with that population of NSTEMIs. So I totally recognize the OMI paradigm. I want you to think about it. I want you to accept that STEMI is, you can have a STEMI pathologically, but not on the surface EKG. But I don't think we should be bending over backwards to bring more and more people into our STEMI system. There's a lot of work there and there's some risk. Case 7 is one that I put in really, again, in defense of the middle-aged guy. And I call it, but I did everything right. Here we are, we're bouncing through the streets of Portland, middle-aged guy, middle-aged woman, having a STEMI, and they turn to you and they say, but I did everything right. Who here has had people say that? People in a CCU, people having, yeah, totally. I did everything right. How come this happened to me? What happened? And I always find that very difficult. And I think this paper, which is out of Mass General, came out late last year, and it's a good reminder to me. We all think that with our clever rating scales, we can predict the future. We can predict who's going to have this is going to happen to. It turns out not necessarily. This is a paper which looks at people who come with a STEMI, and it looks at our best new predictive tool, the Prevent calculator, which we use in primary prevention, in primary care, to tell you how likely you are to have an event and whether you want to treat yourself with statins, etc. It turns out that if you actually go to a hospital, people presenting with ACS and STEMI, and you actually run them to the calculator, and imagine you'd seen them yesterday, half of the people would have been low risk. In other words, our ability to predict this is much less good than we think. And we've cast this in our society as, if you're good, this won't happen to you, and if you're bad, it will. And that's something that goes back in our society and in other things, which I won't point out. And it's baked into our society. If you're good, it'll be okay. If you're bad, it won't. And here's the thing, it really isn't true. Which brings us back to Hemingway. So how did you go bankrupt? The answer is slowly at first, and then all of a sudden. And that's the pathology of STEMI. In other words, those predictive things being good predict the plaque slowly growing every year, 1% from when you're a teenager to when you're very old. But that never killed anybody. That just gives you narrowings in your arteries. It might give you stable angina, but it doesn't actually kill anybody. What kills you is when that artery suddenly, that plaque becomes disrupted. The top of the plaque splits and it gets, that gunky interior becomes open to the blood, and then the blood thinks, hey, there's a hole in the artery, I've got to fix it. And it puts clot on top of it, and it happens very suddenly. And all our predictive models are moderately good. I mean, sort of 7 times out of 10 for this slow thing, but they actually are very poor at predicting this. So recasting this away from good and bad and not making people feel guilty on the worst day of their life is probably a good strategy. What are my take-home points? The results of STEMI management can be amazing. I need to thank everybody here for all their hard work. I have this really difficult job in life in that I have this little, what I call the seal with the bouncing the ball on its nose trick that I can do, and people are incredibly grateful to me. But actually, it's one of the least important parts of this. None of what I do actually works without all of you actually doing work. And I get to see people. I have a nice cup of coffee, I have a warm cath lab, I have Taylor Swift on. It's really a good gig. Whereas some of you are actually in people's homes. It's dark, it's cold, it's scary, they're heavy, and that's really, really hard. And I'm incredibly grateful to everybody. Use the back to front and upside down technique to check for posterior STEMI. If you're still a droid person, I really can't help you. Beware of transient ST changes after ST shocks. Just give it 5-10 minutes, repeat it again. It's sometimes worth it. Remember that not all cardiac arrest, even when it's VF, is primary cardiac. It can be neurological, and I'm afraid they do very poorly. If you don't have a STEMI, don't go to the cath lab after your cardiac arrest. Inferior STEMI, totally open the artery first with cardiogenic shock, and then if that fails, go for an Impala. Anterior STEMI and cardiogenic shock, use the Impala before opening the LAD. Maybe in the future, use the Impala even if you're not in cardiogenic shock. We'll have to wait and see. Remember that Impala CP is only a bridge. If you're going to do this, you've got to be in it. You've got to be in a center where they can actually upsize you to next morning to a 5-liter Impala. I'm really sorry to say the mechanical complications still do very badly, and that is just an unfortunate fact of life. Sometimes a non-STEMI is actually a STEMI, the OMI paradigm, worth bearing in mind. Half of all acute coronary syndromes occur in low-risk situations. Even good people can have a STEMI. So that was all I wanted to say. Before the people in white coats come and carry me off, has anyone got any other questions? Because otherwise I'm actually going to run before they, we're trying to work out which door the people with white coats are going to come in on, and then you try and do the other door.
Nothing online.
No,
Okay.
you did a good job.
You don't have a white coat on?
Pardon?
No, I thought I was waiting for the men with white
He's waiting for
coats.
you to carry him away.
I'd have to get it from upstairs. You should
Okay.
come with me.
Okay, that's good. Thank you so much for listening. Do reach out to me if you have any questions.
Thank
Have a
you.
good day.
I was just starting.
Who's working on helping people get online?
So Tim Long and Christine Bowles and I are trying to resolve the issues that
So-
we're having. I realize there's a number of.
We are recording.
Okay.
It was supposed to, so this is one of those things where we get told it's supposed to be open and everyone's gonna have easy access.
So you probably haven't noticed, but he said he keeps getting asked for his password over. Is that?
I don't have a technical fix for it right now. Like I said, our IT person locally is working on it, and he's reached out to our team's representative as well. So we're gonna.
I'll make sure we share the recording also.
Thank you.
I apologize for IT difficulties. You know how they go. Every year. I think we're gonna be like, this is gonna be the year. Or
This is not gonna be.
no, it's not the year. I want to introduce our next speaker and me a little bit. I don't know where I'm fitting in. When you point to me, I'll say something. Emily has been an emergency department RN for over 10 years of experience. So she's done some triage and she's done some of that psych and that heart stuff and some of this brain stuff going on as well. Variety of a few hospitals in our Oregon area. She originally comes from
Atlanta.
Georgia. I was like, Georgia? She returned to school, got her master's of public health, and she joined our team as the stroke coordinator here for our comprehensive stroke center here at St. Vincent Medical Center. I want to say 2023. Has it really been? Okay. I kept looking at the time. I'm like, no, time flies when you're having fun. And I'm Diane Clark. I'm an acute care nurse practitioner I helped open our neurocritical care unit here at St. Vincent Medical Center, and I point fingers at people to do things.
All right, well, thank you all for joining us today. As Diane mentioned, I have a background in ER nursing, and triage was always one of my favorite things to do. I know it's not everybody's favorite, but I always really enjoyed kind of playing guess the workup and trying to see if I was right about where I thought that the patient's symptoms were pointing to in terms of an ultimate diagnosis. And that is one of the things that I think is most frustrating about stroke triage, especially from the EMS perspective, is that we don't have a good way to tell you if you were, quote unquote, right about whether or not the patient you thought was having a stroke ultimately was having a stroke. And so we're going to go over some stroke triage examples today. We'll talk about code stroke basics, what the process does and how it works. Review acute stroke treatments and triage tools, the 2026 AHA guideline updates for acute stroke treatment, talk about stroke mimics, and then a little bit more information about code stroke treatment process that's more focused toward our ED nurses that are joining us today. So some stroke facts, many of these you guys have probably heard, they get repeated a lot, and then there are some up here that might be new to you. These come from the 2026 Heart Disease and Stroke Statistics Report from the AHA that came out in January. So roughly 80% of strokes are ischemic, 20% are hemorrhagic. That's familiar, right? 10 to 20% of strokes occur in adults under the age of 55, which is something that always surprises people, I feel like, when we say it. On average, in 2023, someone died of a stroke every 3 minutes and 14 seconds. Stroke accounts for approximately 1 out of every 19 deaths in the United States. And ischemic stroke is heritable, although heritability estimates vary by the stroke subtype. One large study that was published recently estimated heritability of ischemic stroke to be 37.9%, which is kind of interesting to think about. So, code stroke basics. Code stroke is a process that was originally designed and pushed out to sites by the American Heart Association as part of the Target Stroke program to help speed door-to-needle and door-to-device times for patients. With the goal of getting care fast to patients who may be having a stroke and who are eligible for acute stroke treatment. So that may be having a stroke category, that's a really big bucket, right? That could be happening to a lot of different people in a lot of different situations. But the eligibility for acute stroke treatment is a much narrower group. And those are the patients that we're most interested in catching as fast as possible so that we can get them treated. When you activate a code stroke in the field or in the emergency department, it functions the same way. So it assigns an ER doctor for an emergent evaluation, so it pulls them out of whatever they're doing. It notifies an ED or at night, depending on coverage, the central ICU pharmacist to also drop what they're doing and prepare to evaluate the patient's case in case they can be given IV thrombolytic. It immediately clears a CT bed for a patient, pages the stroke neurologist on call for an emergent eval, and notifies the stroke coordinator and the house supervisor and a number of other people in different roles that we have a patient who might be acutely treatable coming in. The reason why we do all of this stuff and we work on this process constantly is because the time to treatment for these patients really matters. For every additional 15 minutes of delay, more patients die, fewer patients are able to walk independently at discharge, and more of our patients discharge to a nursing home. And for every 15 minutes acceleration in the start of TPA, an IV thrombolytic drug, after symptom onset, is associated with 4% greater odds of a patient walking independently at discharge, 3% greater odds of being discharged to home rather than an institution, 4% lower odds of death before discharge, and 4% lower odds of experiencing a symptomatic hemorrhagic transformation of their stroke. So acute stroke treatment, what do we actually have to offer people? 3 main modalities for acute stroke treatment for our patients. First is IV thrombolytics. So these are medications that break up clots in the brain. The 2 that are FDA approved are Alteplase, which is, ancient for us now, and Tenecteplase, which was actually FDA approved in March of 2024. So very, very exciting. We had been using it off-label in Providence within the Oregon region, as were a lot of other sites. But it's now FDA approved and it's officially recommended by the AHA for acute stroke treatment. The eligible time frame, so the patients who can get this medication are those who are 0 to 4.5 hours from their last known well time. Patients who can't receive IV thrombolytics are those that have a recent large stroke, patients who have an active brain hemorrhage that we can see on CT when they come in, and patients that have had neurosurgery or a traumatic brain injury within the past 2 weeks. And of course, a caveat, it's always important to know the patient's anticoagulation status when they come in because that also affects their eligibility. Second acute treatment modality is endovascular therapy, or EVT. This is a procedure to pull clots out of the brain, and we can do it after you've received IV thrombolytics as well. The eligible time frame for this is 0 to 24 hours from last known well. Patients who can't have EVT are those who don't have what's called a large vessel occlusion, or LVO, on their CT angiogram. Patients who have a large vessel occlusion that is too far out or too difficult for us to reach with the catheter. Now, this varies by facility, but there's generally accepted a number of vessels and spots where we can get these clots. And then beyond that, it becomes, an issue of how specialized the facility is at getting the clots. And then there are recommendations against going for clots that are too distal or too far out. And then also patients who have too much brain tissue that's already injured on a CT perfusion scan. So the green and the pink that you guys see down there, the pink is tissue that we can see on the scan that's already injured, has signs of ischemic injury already. And then the green is tissue that is at risk in that vascular territory. So the area that could continue to infarct if we don't take a clot out. And we look at the mismatch between those two things on CTP and make the decision about whether or not there's enough brain left to save for it to be worthwhile for that patient to go for an EVT. You can see there, that's a basilar clot that was pulled out with a little solitary device. The third modality of acute stroke treatment that I feel like we don't necessarily talk about enough is neurocritical care. This is specifically for our hemorrhagic stroke patients. We need to stop the bleeding in the brain. We need to do emergent blood pressure management for these patients and anticoagulation reversal. And we need to get them to neurosurgery as quickly as possible for evacuation of the hematoma, relief of obstructive hydrocephalus with an EVD or a drain, and possibly craniectomy to relieve pressure on the brain and prevent herniation of brain tissue. Early intervention for hemorrhagic stroke patients is extremely critical. We want to give the first blood pressure lowering medication within 60 minutes of arrival to the emergency department. We want to reverse anticoagulation within 60 minutes, and we want to have the patient evaluated by neurosurgery within 90 minutes of arrival. And the slide there that you guys see is pointing out two really important aspects of acute intracerebral hemorrhage care. The first is that the volume of blood in the brain is the main predictor of mortality at 30 days. And you see that 30-day mortality prognosis there starts at 19% for small volume hemorrhage, goes up to 91% for large hemorrhages. So these patients have a very high mortality rate. The probability of volume expansion or continuing to bleed into the brain is highest within the first 3 hours of symptoms for hemorrhagic stroke. So that's when we want to be able to do absolutely the most for our patients to slow down the bleeding and stop it and treat the issues that they're having with swelling. Key considerations for acute stroke treatment. We used to say back in the day that we would not treat patients over the age of 80, for example. We don't care about age anymore. What we want to know is what their baseline functional status is. How independent were they before they had their stroke? What was their quality of life? And for that, we don't want EMS to be trying to figure this out on site. We want you to get the name and contact number for family and let them know that someone will be calling so that the neurosurgeon and neurointerventional radiologist is able to talk to them and get consent for an acute treatment if possible. Out on the table out there, we have these stroke emergency contact pads. They look like prescription pads. These have been distributed through AMR and Providence as a joint project with the goal of having them handed off to the patient's family member on site, get it filled out. They give that piece of paper back to you and you take it with the patient into the emergency room. So we have a head start on who to call, and that person that we have the number for is expecting a phone call, because there's nothing worse than having the neurologist, calling 5 different people on the phone trying to get somebody to say yes, this is what we should do. We want to try to get last known well time, like 1500 or 2 p.m. instead of like 1 hour prior to arrival, because that starts to get confusing when everybody's trying to figure out where they are on the timeline. And we want, transportation as soon as possible. Additional information, we'll figure it out when they get here. So stroke triage tools, be fast. This will be familiar to everybody. This tool specifically comes from Multnomah County EMS protocols. BFAST tools vary among institutions. So this BFAST tool has some slightly different wording than the BFAST tool that comes from the American Heart Association, for example. And it also has slightly different wording than the BFAST tool that we use in the emergency department at St. Vincent's. And some of the differences in wording do wind up mattering when you're deciding whom to call and as a code stroke. And we'll talk about that when we get into our stroke triage. But right now we'll go over the basic components of BFAST and some tools and tips for each section for how to interpret it. So starting with the B, the keyword here, B for balance, is sudden change. So sudden loss of balance, patient says they can't walk straight or they're listing to one side, or report of dizziness, sudden onset of dizziness. Dizziness is, I think, gosh, I want to say it's like 30% of ED encounters report dizziness as one of their symptoms. It's extremely common. It shows up in a lot of different clinical profiles for a lot of different diseases. And so for stroke, we want to figure out how we can be most specific in interpreting dizziness. And so there's a project out of St. Charles that was actually published at the International Stroke Conference a few years ago, developing these additional questions to target dizziness. So the questions are, did the dizziness start suddenly within the past 24 hours? Does it come and go, or is it persistent? Is the room spinning or shaking, or do you feel like lightheaded or woozy? And does the dizziness change with position? If the description of this dizziness is sudden, persistent, spinning or shaking in nature, and non-positional, then we would triage the patient as a stroke. And this is a tool that we are rolling out in our emergency room right now at St. Vincent's, and it's something that's in use at a lot of other hospitals. So it's an excellent way to kind of help you narrow down what kind of dizziness you might be looking at. Moving on to eyes, does the patient have trouble seeing out of one or both eyes? I personally got into an argument with another nurse in triage once because I had a patient came in with blurred vision, sudden onset, bilateral. And she told me we couldn't call a code stroke because it was in both eyes. And we would only call a code stroke if the deficit is in one eye or the other. And she and I were both a little bit wrong. Eye changes for patients with stroke are typically painless. Oftentimes a visual field cut or this vision going black report, double vision, nystagmus, but not just blurred vision. Sometimes patients will say, my vision is blurry, and really what they mean is that they're having some other defect in their vision that you'll be able to see when you test all 4 quadrants in their exam. Yeah, you want to get more specific, ideally with your exam when you hear just blurred vision, because blurred vision mildly, is associated with a lot of other medical issues, but is not a very common individual stroke symptom. You've also got here your gaze, a disconjugate gaze and conjugate gaze examples, and then of course the left-sided homonymous hemianopia, which is a visual field cut on the same side in both eyes. So F and BFAST stands for face. You're looking for a droop or flattened nasolabial fold. You want to ask the family, does their face look different? Because sometimes that has been that way for a long time. One of the kind of clinical decision points you have when you're talking about facial droop is whether or not this might be Bell's palsy. Bell's palsy is a peripheral facial nerve palsy, and it causes weakness in the upper and lower portions of the face. Most cerebral strokes cause weakness of the lower face only. Brainstem strokes can cause weakness both upper and lower face, but with a brainstem stroke, typically the facial droop is not going to be the only symptom that you see. Typical presentation of Bell's palsy is there on the right. You can see how on the right side of that man's face, he's got failure to move his eyebrow, and he's got drooping of his eyelid as well, and then drooping of his lower face. And then a cerebral stroke is on the other side, and she just has lower facial droop there. Typical presentation for Bell's palsy, median age is 40 or so. So 20 to 50s. Acute stroke tends to happen in older patients, although we know that there is a significant percentage of strokes that do happen in that same age range. Bell's palsy tends to gradually appear over hours to days. An acute stroke is typically sudden onset of the facial droop. And then, of course, upper and lower face are both affected for Bell's. And there are rarely associated symptoms with Bell's. People don't describe, facial numbness very often, and they don't describe any of the other stroke symptoms that we see, like weakness, speech difficulty, slurred speech, visual changes, things like that. Looking at the A for arm, for the BFAST tool for arm, weakness means drift. So hold your arms up for 10 minutes or 10 seconds, excuse me, not 10 minutes. I wouldn't pass that either this morning. Hold your arms up for 10 seconds and you're watching for subtle drift. I mean, they don't always go all the way down and hit the bed. Not grip strength, right? We don't test grip strength necessarily to evaluate weakness. We are specifically looking for arm drift. And as I spoke about before, BFAST tools vary, and some of them call out that numbness independently is positive for the A for BFAST. So like if a patient does not have drift, but they have arm numbness, some BFAST tools specify that that is positive on the BFAST tool. The recommendation from the American Heart Association that's clarified and kind of reiterated again in 2026 is that for patients for whom numbness, unilateral numbness is their only symptom, unless that is disabling to them, like unless they are a concert guitarist or something and it's their right hand that's numb and now they have loss of function, we are not recommended to treat those patients with IV thrombolytics anymore. So that's something to keep in mind. But of course, we're not teaching to your hospital or your facility specific protocol. And if you have a BFAST triage tool that you are using, you should follow the recommendations in your tool. And we'll discuss that further when we talk about the stroke triage examples. Additional concerning symptoms for stroke that don't show up on BFAST. We've got the 5 Ds of posterior stroke. So dizziness, dysmetria or incoordination, ataxia, diplopia, double vision, dysphagia, difficulty swallowing, and dysarthria or slurred speech. And then you've got some other indicators of brainstem or posterior circulation stroke on the graph there. One of the things that you will see that's interesting with brainstem strokes are what's called crossed signs. So typically you think we'll have weakness on the right, but with brainstem strokes, you'll have like left facial droop and weakness on the right limb. And that's indicative potentially of a brainstem stroke. So headache is another indicator for code stroke activation. We're looking for headaches less than 24 hours old, that particularly ones that are described as thunderclap or sudden onset, worst headache of my life, and headaches that are associated with altered level of consciousness, disorientation, or loss of consciousness, with BFAST positive symptoms, with intractable nausea and vomiting, seizures, or neck pain and stiffness. And I wanted to point out here this thing called the Scan Me tool. This is a project that was presented at the International Stroke Conference. And they developed an EPIC tool to help them identify in the emergency department quickly which headache patients needed to be scanned immediately. So they asked these questions, worst headache of your life, sudden, severe or seizure, change in position or quality, altered mental status, associated with other neurological deficits, medications without relief, and does the patient have elevated blood pressure or temperature? And then if you had a score of 3 or more, this would be an acute stroke activation based on that project that they did. So I think that one's pretty interesting and something that we might be looking at further at our hospital as a way to help triage these headaches. So CSTAT, again, this comes from Multnomah County EMS protocol. CSTAT is used after BFAST to identify large vessel occlusion stroke patients potentially who need to go to a center that is capable of doing a thrombectomy. A lot of hospitals are not thrombectomy capable centers, and you don't want to delay that patient potentially getting to treatment. BFAST is positive automatically if the patient has a gaze deviation. Gaze deviation is 2 points. If they have arm drift and they are not able to answer at least one level of consciousness question or follow at least one command, then it's also positive BFAST. One thing that we do want to mention is that research shows that the transport of patients with potential large vessel occlusion to very far away thrombectomy capable centers, 45 to 60 minutes away, does not seem to improve 3-month clinical outcomes for these patients over transferring them to their closer stroke center, because the endovascular therapy is not the only thing that we can potentially do for them. And if we spend a lot more time transporting them to a thrombectomy capable center, we might be missing an opportunity to, for example, treat them with IV thrombolytics sooner. So moving on to 20 and 26 guideline updates from the American Heart Association. These are intended for pre-hospital providers all the way out through post-discharge rehab providers, so the full spectrum of care. The gist of the updates for the guidelines is that we have more treatments available for more patients. Dr. Kansara is going to be going over some of this stuff in more detail later, but we have an extended window potentially for IV thrombolytics. You know, we said up to 4.5 hours, now maybe up to 9 hours. Wake-up strokes can potentially have IV thrombolytics. We've expanded eligibility for endovascular therapy to patients who have a bigger or large core stroke and patients who have more difficult to reach clots. And we have pediatric stroke guidelines for the first time, officially from the American Heart Association, that say that we can treat children with alteplase for potential strokes, and that children over the age of 6 should be considered for endovascular therapy potentially. And of course, in Oregon, those patients go to Dornbecker. They do not come here, ideally, if you think a patient is having a stroke and they are under the age of 18. We are an adult-only treatment center, and we would begin immediately trying to transfer them after we get them a pediatric neurology eval.
We do have a pediatric ED. I mean, like, do your local.
Yes, yeah. Sorry, yeah, do follow local protocols. But from a stroke program perspective, our plan is to transfer them to a specialty center. So treatment eligibility, the big picture, the patients we do not have available treatments for are patients whose last known well is greater than 24 hours. So that is the clearest, most obvious contraindication to a code stroke activation is if you have a last known well greater than 24 hours. But these patients, if it's not a code stroke, they're still a high acuity patient who needs an emergent eval. You know, from an ED nursing perspective, they're an ESI 2. And we want to get them seen and evaluated as quickly as possible. Your neuro concern is real, whether or not they fall into the acute code stroke protocol or not. So what about stroke mimics, things that look like stroke but ultimately are found not to be? First thing is that there are a lot of them. Up to 40% of patients that come to the ED with stroke symptoms may ultimately be diagnosed as a mimic, and up to 16% of patients treated with IV thrombolytic in large hospital-based registries were ultimately diagnosed with a stroke mimic. However, these patients who have a stroke mimic and get TNK or alteplase are the safest possible patients to treat accidentally. They have very low rates of treatment complication for IV thrombolytics. And they typically do very well. However, the misidentification of stroke mimics, the inability to kind of weed them out, does cause other harm. It leads to unnecessary imaging. It leads to unnecessary cost within the medical system. It delays their diagnosis with what they actually have going on. If we are barking all the way up the stroke tree and doing an extensive workup, it might kind of shift us from where else on the differential we need to be looking. It uses a lot of resources. As we talked about, the code stroke process automatically activates a lot of different modalities. And it's a psychological burden for patients. We give patients IV thrombolytic and then call them and tell them that we don't think that, you know, they need to follow up with us. We didn't actually have a stroke, and they kind of have a hard time dealing with that. So most common stroke mimic is hypoglycemia. As an ER nurse, I personally, especially as a baby nurse, have seen a couple of times people come this close to treating a patient with IV thrombolytic who was hemiparetic, completely down on one side, and got the blood sugar back and it was 30. And they magically resolved. I mean, it's crazy. So hypoglycemia, we always check first. Regulatory requirement is that we have to have a point of care blood glucose before we can administer IV thrombolytic. Seizure is another common stroke mimic. Peripheral vertigo, right? These are our dizzy patients who don't meet our 4 additional triage questions. Migraine, complex migraines will present with, facial weakness and a lot of other symptoms sometimes. Functional neurological disorders, which we, back in the day used to call like psych stress-related responses that sometimes present with focal neurological symptoms, and altered mental status or syncope for various reasons. So we're going to go through some acute code stroke triage case studies. We'll give you the story. Everybody in the room give a thumbs up if we think that code stroke should be activated or was activated. And then we'll ask, was this activation within the protocol? Was the patient BFAST positive? And then we'll go over what their outcome was clinically. Okay, first case. Patient ambulates to triage, complains of chest pain, left arm numbness, and dizziness, started at 9 o'clock today. Bilateral equal grip strength, and patient is on Eliquis, so anticoagulated. Vital signs as above. Do we think that this patient got a code stroke activation? Show of hands, I can't see. No? Okay, so they did get a code stroke activation. You see that BFAST screen for stroke symptoms there underneath the vital signs? That's the tool that's in use at this emergency department. And arm weakness or numbness is positive. So this patient was identified using that BFAST stroke screen tool. And that activation was within protocol. So ultimate course for this patient, the stroke activation was canceled and they were admitted to CDU for a cardiac workup. So show of hands, who has had one of these cardiac seeming kind of patients come in and actually get stroke treatment or ultimately be diagnosed with a stroke? Like within the last couple of weeks, we had a patient that came in with a very similar presentation and they ultimately were found to be having a stroke for which they were treated. We're going to, obviously in the previous presentation and in further presentations, we'll talk about the, the interrelatedness of cardiac issues and stroke, but they can co-occur sometimes. And so it's something that you do always want to consider. Even if it 100% sounds like chest pain, it's worth having that thought about whether or not this might also be a stroke. All right, next story. So this is another triage patient, arrives for intermittent right-sided weakness, numbness, hemianopsia, and severe left-sided pressure headache for 1 week. Vision changes and headache came on suddenly, but have come and gone. Weakness and tingling has been persistent. And the patient reports that they woke up with vision changes this morning at 10, but that they've gone away now. So thumbs up, did we activate? How do you know? Okay. Okay, so yes, this patient had a code stroke activation. Was this activation within protocol? Yeah, that was a no. So this patient, a 50-year-old female with diabetes, high cholesterol, and hypertension, was not a candidate for any acute intervention because of last known well 1 week ago. She's reporting changes and new symptoms at 10 a.m., but her last known well time before it all started was a week ago. And sometimes things, people describe these things in the most confusing way possible when they try to reach back and say like, well, when did it really start? But when we get past 24 hours for abnormalities, then we are outside our window for treatment for these patients. All right, next story. So this is an EMS in the field activation. A 69-year-old female was CSTAT positive, last known well at 9:30 with head and neck pain, now having agonal respirations and being bagged. When they arrived to the ED, we got the narrative of chief complaint. The neighbor called, a patient called the neighbor because they had a headache. And then 5 minutes later, the neighbor found her altered. So code stroke activation, yes or no? Yep. Activation within protocol. Yes. So this patient was found to have a diffuse subarachnoid hemorrhage. She had MAPS in the 40s despite nicardipine, so she was very hemodynamically unstable, and she ultimately transitioned to comfort care and passed away within 136 minutes. So excellent recognition in the field. They got her to the hospital as fast as they possibly could, and everything went right. And it just serves to highlight, I feel, how critical these hemorrhagic stroke patients can be and how little time we have potentially to intervene. All right, 58-year-old male presents to triage with complaints of slurred speech, numbness of left hand, and a recent fall. This happened at 2 o'clock yesterday, and it's 10:38. I don't know if you guys can see that very well, but the patient arrived at 10:38. So What do we think? Code stroke activation, yes or no? Yes. Activation within protocol, yes. So patient was not found to have a large vessel occlusion. He didn't get TNK because he was out of the 4.5 hour window. He did have an ischemic stroke, and you can see it there on his MRI. It's a right posterior frontal centrum semiovale region stroke. So excellent activation through triage there. This is an in the field activation, 79-year-old male, left-sided weakness while hiking. GCS was 11 and now 14, so it had some alteration in consciousness. Got D10, and then vitals are there. So when they arrived to triage, we get some more information. Patient had this falling episode with lightheadedness and tried to lower himself to the ground prior to passing out, and then bit both sides of his tongue during the event and doesn't remember what happened, right? So we have lightheadedness prior and kind of a seizure sounding example. So activation of code stroke from the field was positive, right? With the information that they had. Was this activation within protocol? Yes. So given the description of event, loss of consciousness and quick recovery with possible transient hand weakness, there was a low suspicion for a vascular event for this patient, and he was worked up for cardiac syncope ultimately. But this was an activation within protocol. This patient got the right care. All right, another activation from the field, 59-year-old female, last known well, 1750, nonverbal with slurred speech. Arrives to the ED, and we get some more triage information. This patient has a history of asthma, obesity, anxiety, back pain on opioids, and a recent L5 compression fracture, and now has limited ability to speak with some slurring. Non-focal exam. So code stroke was activated. Was the activation within protocol? Yes. Yeah, patient was presenting with a speech deficit that was recent. Further information during the workup, we found that the patient had been taking oxycodone 10 milligrams since the back injury, and then her alcohol level resulted at 382. And she confirmed that she did have, quote unquote, something to drink that day. So it's tempting when you get a patient like this where it's like, oh, they were drunk, they were drunk, like that, to look at that activation. But given the information that you had when you started, right? This was a very reasonable activation decision. And this patient needed to be evaluated quickly and got to the right level of care. All right, so another EMS activation. Patient arrived with left facial droop and difficulty speaking. Last known well was at 16:30 the day before, and it's like 10:39. Code stroke activation was positive. Was the activation within protocol? Yes. This patient was also found to have an ischemic stroke out of the window for IV thrombolytics, and did not get into vascular therapy because they had no large vessel occlusion. 53-year-old male brought in by son for gait problems since Sunday. Grocery shopping and started veering to the left. Called EMS at the time. Blood sugar was over 500 and blood pressures were high. Decided not to go with the ambulance, reports that he hasn't been taking his meds for about 8 months due to a lapse in insurance. Was this patient activated as a code stroke? So, in fact, not. This patient, they did not choose to activate on. And that decision was within protocol because he is reporting a last known well of several days prior to arrival. He was outside the window for acute stroke alert as symptoms began multiple days ago. But when we got his MRI, there were abnormalities there, and his differential diagnosis includes a lot of different kinds of neurological issues. But it was a good call not to activate him as an acute code stroke. So any questions about any of those examples from the room here? All right, well, so we'll go through and talk about a little bit more code stroke process. Basically, the code stroke process is mapped out from the level of stroke awareness in the community, right? We do community interventions to help people recognize the signs and symptoms of stroke so that they can activate EMS for themselves early. And EMS has processes in place to transfer them to the right level of care in the emergency department and to get them potentially telemedicine eval if they need to that. to get early imaging to diagnose a stroke and be able to treat them, and then to discharge those patients to the right level of follow-up care so that they can continue to have appropriate therapies post-stroke. Goals for EMS provider care generally are for a rapid assessment process to be followed, transfer to stroke center to happen quickly, with pre-notification that an acute stroke is en route with a CSTAT status. I get the code stroke pages in my inbox, and we do see a lot of activations in the field without CSTAT status documented or shared. And so that's one thing that we would ask, is that we try to always say it's CSTAT negative if it's negative, for example. And the clock time, so like 1500, 1400 for last known normal, as opposed to like last known normal 30 minutes prior to call or something. We want you guys to get vitals, glucose, and know about their anticoagulation status, to bring a list or bag of their medications, so we always do, and to obtain the phone number for witnesses or family. So we've got our pit crew picture here to kind of illustrate how fast we're trying to move everybody at the same time to get from door to decision for acute stroke treatment. We need to get a bed weight, a point of care blood glucose, a CT scan, and labs pretty much immediately on arrival. We need to be able to help the neuro provider with their exam, particularly if they're on telestroke, and review treatment contraindications quickly. We don't need to get these patients into a gown. We don't need to hook them up to cardiac leads. We don't need to room them immediately, and we don't need an immediate EKG or chest X-ray. All of those things slow us down in the decision-making for acute stroke treatment. And so we want to de-emphasize those aspects of care when they first arrive. If the patient is a yes for TNK or IV thrombolytic, you want to confirm their weight, make sure you have a good IV, and make sure that their blood pressure is below 180/105. If they're a no for TNK, the question is, do they have a large vessel occlusion? If so, you want to prep them for transfer to the cath lab immediately. And if they are a no for endovascular therapy, then we would downgrade that patient, and we would get our bedside swallow exam, start doing neuro checks according to unit protocol, typically every 4 hours, et cetera. And the goal for ED code stroke process optimization is really to have specially trained nurses in stroke response who are kind of quarterbacking the patient through the process, because it really goes a lot more smoothly if there's one person that's kind of leading it on the bedside team. And the ED nurse tends to be the best option there. So some telestroke tips. Many facilities use offsite neurology. A lot of hospitals only have offsite neurology. And like St. Vincent's, for example, has providers both on-site and off-site, depending on the day and the time of day. The main thing is to take the stroke robot to the patient's room. This is our, it's called OR-PSV1, our stroke robot in the code stroke zone at St. Vincent's. And that's Dr. Kansara's little face up on the screen, waiting forlornly for someone to move him to the patient's room so he can see the patient. But we also have a stroke robot in the CT scan room as well that's up on the wall. So providers have multiple options to log in, but we want to get whatever modality they're using for telestroke to the patient's bedside. Position the robot at the foot of the bed off to one side and stay in the room with them to help them with their exam. So the provider they're great at doing a lot of things with their camera and zooming in and toggling and moving the robot around and talking to the patient, but they cannot do an actual decent NIH-SS exam without your help. They can't really assess visual fields well. They can't check for numbness or sensation for these patients. They can't get the patient up to potentially walk and look at a gait deficit. They can't feel grips. They can't test gag and airway. So your help with that assessment is essential. And if we've got a million things going on, we're getting pulled in all these different directions, and we walk out of the room and leave the patient with the robot, we are going to be hindering that patient's ability to get the care that they need potentially. So that's a big thing that we want to emphasize. And blood pressure management, finally, for acute ischemic stroke in the emergency department, right? We don't want to pre-treat patients for blood pressure that are potentially having a stroke with EMS. But in the emergency department, after a CT head, and we've determined whether or not they're eligible for TNK or EVT, The recommendation is for the blood pressure to be managed below 180 over 105. And we would have a very low threshold for starting IV blood pressure drip. So typically we'll start with nicardipine as a second option to labetalol if labetalol is not working. What we don't want to do is spend a lot of time trying to get the blood pressure down without, being aggressive enough and delay that patient's IV thrombolytic administration. All right. Are there any questions? Yes.
I'd like to ask, so EMS brings you a patient positive for stroke and they go, oh, they're on Eliquis. What are some things that come to mind or precaution that you would have regarding patients on Eliquis that are becoming more common?
When you say precautions,
I guess not precautions. What are some things that immediately go through your mind when you hear, oops, as it's becoming more?
When we hear,
bleeding,
yeah, so
things.
when we hear Eliquis or Pradaxa or rivaroxaban or warfarin, warfarin, we can check INR and see how therapeutic they are. We're always thinking, okay, well, this might be somebody I can get for an endovascular thrombectomy only instead of actual IV thrombolytic. But again, our diagnostic tool is that CAT scan. So I want that CAT scan. Is there hemorrhage in their brain that I'm going to have to reverse? I'll throw out, no, I won't go that way. There's just up and coming data. And again, the guidelines that were just released like 2.5 weeks ago, online only. So they're not even in print yet, except for that I printed some. So there's a lot of evolution of thought going on right now with when do we introduce CT perfusion and who gets it, up to that 24-hour time frame. And there's going to be a lot of changes, I think, coming over this next year. I think we just happen to have lucky timing to closeness to that release of the new guidelines, and International Stroke Conference just happened last week too.
Yeah, I think one thing I want to mention about, we've mentioned a lot about new guidelines and, more treatments available and everything. It's, as an ER nurse working with these patients, I remember many years ago feeling just kind of sad about what they looked like when they came in, and this sense that most of them were just going to wind up in a nursing home ultimately, that we didn't have a lot of acute treatments to offer them. The window for treatment was so narrow when it first became available. And as the years have gone by, we've gotten more and more and more opportunity to do things for more patients. And right now, like currently, St. Vincent's is involved in a clinical trial for a medication. It's called the FASTEST trial, for a medication that helps the hemorrhagic stroke patients as well. And the preliminary results of that are positive. And so as we move forward with these new guideline updates, I just want to give you guys a sense of how exciting it is, how many more people we will potentially be able to acutely treat, which is stressful in its own way, because now, all the things that we're working on to go faster and faster and be more and more tightly organized are going to have to get even better, because now we have a larger group of people that we can potentially do something for. But it's an awesome opportunity for all of us, I think.
It sounds like there's an online question before somebody else, sorry.
Yes, I'll go ahead. So ED triage nurse here. I had a patient walk in who had an episode of about 5 minutes of aphasia, approximately an hour prior to arrival. Completely resolved on arrival. The ED doc told me to call a code stroke because it was within the 4-hour window. My understanding has always been not calling a code stroke if symptoms resolved. What are your thoughts?
So that patient's activation would be within protocol. So patients can have what are called stuttering symptoms sometimes. So you'll start to have your symptoms and then it'll get better. It'll kind of wax and wane. And sometimes what winds up happening with those patients is that the little clot that's kind of moving around in that vessel sticks. And then we have a completed stroke. Also, that patient, if they're having a TIA, ultimately, if that's what they get diagnosed with instead of a treatable stroke, we do still need to, rapidly move to treatment for them, because TIAs are predictive ultimately for many patients of an actual stroke within, I think, like a year or two.
Yeah, especially the first 7 days.
Especially the first 7 days, yeah. So the protocol for us is be fast positive and symptom onset within 24 hours. There's nothing about whether or not symptoms have resolved. And so you don't need to kind of go that far down that rabbit hole. If they had an experience of symptoms, you want to activate and get them evaluated. They may very well not be treated, and that's totally fine, but we definitely want to activate for those patients. Oh, sorry, you had your hand up first. Mhm.
Do you still, I'm a paramedic, do you still want us evaluating for grip strength? If so, are they weighted similarly or is drift more indicative than grip strength? Like, you know.
Do you want to?
Yeah, so technically drift is weighted heavier than grip strength. So being able to hold up the whole entire arm takes a lot more motor homunculus or brain tissue. The hand grip is actually a much more detailed exam. So you may notice, you know, a weaker grip or whatnot, but if they do have no drift, that's technically not a stroke activation alone. If there's something else.
So in terms of like a hypertensive stroke patient, is there a benefit to EMS getting the available review?
No, that was actually published, actually in these guidelines, like they found, there's been a few studies in the last few years that have actually studied it. And there's more harm than benefit. The ones that it helped were unfortunately, well, fortunately, in some ways, I guess, were the hemorrhagic stroke patients. So we're always looking for those patients, but remember that's, and actually in Portland, it's like 15% of strokes are hemorrhage compared to 85% being ischemic stroke. So we could be harming a lot more patients than we're really helping. So it's do not do it is the recommendation.
Yeah, and without that imaging, we don't know like what kind of stroke they're having. And the evidence for harm, if you lower the blood pressure for ischemic strokes too much is there. And then you just don't have enough information to make the decision.
Yeah, and unfortunately, kind of like Dr. Crispin, he's got his EKG, you've got your EKG, you can get it on your phones and whatever, and it gets transmitted. Our diagnostic tool is our CAT scan.
Mobile stroke units have a CAT scan in them.
There's, and again,
we're not there.
Yeah. We're not probably going to be there in the metro area here either.
Yeah.
There's plenty of hospitals kind of spread out in general. One more question, I
yeah.
think, online.
Yes.
Oh, there's one more here too, sorry.
I think this will be a quick one. To clarify, if there is one positive on the BFAST symptom within 24 hours of last known well, do we call it code stroke?
Yes.
That's the triage, yep.
I wasn't clear, right? Is anticoagulation a total contraindication then for thrombolytic therapy or not?
I would say not an absolute contraindication.
It's a lot muddier than it used to be.
Yeah, there's been some studies testing treatment while they're on, especially the new novel anticoagulants, the direct acting anticoagulants. And
Just what some of those?
that's rivaroxaban, apixaban.
No, but I mean,
So, like-
some of the things that we're thinking about. Except
How recently they've taken it? Like, what time in the morning? Like
Yeah.
literally that detailed. There are lab tests that we can run to look at how the anticoagulant is functioning and what level of actual function it has in their system. Those tests are not fast at our hospital. It's kind of a process to get things like that set up, but there are a lot of other decision points that we can use now to look at potentially treating patients that are anticoagulated, but it's not going to be common, I think, for a while. Last question.
And then warfarin, by the way, you never know if they're therapeutic or not, honestly.
Mhm.
Is the recommendations to family for genetic testing? And if they test for those markers, are there any preventative measures?
So that's a whole field of study, and I am unfortunately not absolutely the best person to speak to it. The hereditary factors are more influential for small vessel stroke. And so the research has focused on what potentially people can do if they know that they have a history of small vessel stroke in their family. And that's something that I'd like to learn more about too, but I'll have to defer that question for now.
Okay, we All right, welcome back, everyone. Thank you again for joining us. Hopefully you got a good stretch break. We've got 3 more lectures to kind of get through, and hopefully we'll keep you on your toes. I'm going to introduce our next speaker, Diane Johnson. She's a paramedic. She works with AMR. She's been with AMR. I guess I should read my paper. Is a quality improvement analyst with American Medical Response and an experienced EMS leader with nearly 20 years of frontline and system level experience. She's a nationally registered paramedic with a bachelor's degree in paramedicine and emergency management. And she specializes in evidence-based quality improvement, EMS leadership development, and data-driven system design. She has led initiatives that significantly improved cardiac arrest survival, modernized operational and billing workflows, and strengthened EMS education programs across rural and regional systems. And today, Diane is bringing us some practical clinician-informed perspective on how driving meaningful and sustainable driving meaningful and sustainable improvement in EMS organizations. Hold on.
Numbers on there, so.
And just want to double check that they can hear us. Yes. All right, let's go back to this. We're good. Okay. Thank you. Thank you. Good morning. We all refreshed? A little bit, maybe? Good. All right. So Diane Johnson, I'm the QI analyst for AMR in Clackamas County. Recently relocated from Southern Oregon and distantly relocated from Arizona. I've been with AMR for coming up on 20 years. Most recently, I am the QI analyst. What that really translates to, for anybody who's not really nerdy like me, it's okay. I'm very nerdy and I take pride in that piece. Everybody needs a resident nerd, and I get to be that one for AMR Clackamas. But basically, what I want to talk about is kind of some of the nuts and bolts on quality, especially as it pertains to EMS. Today. I do not have any financial disclosures, though I do have to credit some of the data you guys are going to see to GMR Medicine. Global Medical Response is the parent company for American Medical Response where I work, but I don't have any financial disclosures other than that's my full-time gig. And then I have to credit the ESO Collaborative for some of the data you guys are going to see today. So what is quality in EMS is something that is emerging and still remains to be established. All of healthcare professions, they have metrics that they meet. We see them in hospitals. We have meetings about them, all of those kinds of things. Traditionally, quality in EMS has been determined by response times, how fast you get there. Because that is where our roots lie. When the 1960-something white paper came out, they said, how quickly do you need to get somebody in cardiac arrest with a defibrillator? And they determined right around that 8-minute mark is where we have the most success. If we can get to them within 8 minutes, that was our most success of defibrillating a patient. So we were judged based on response times and response times alone. However, what we have been doing for many years is healthcare. And to elevate ourselves to that point of, no, we are also doing healthcare, we also need to look at what we do as healthcare professionals. So for quality initiatives, there's a few key elements that we want to focus on. And for today, I want to focus on what are the measures, because those do seem to be the most misunderstood piece of quality initiatives in EMS. We all ask ourselves why. Why must we do all of these things? And it is because we are, in fact, healthcare professionals. We are out there in the streets. We are doing medicine at 3 o'clock in the morning at 75 miles an hour. In the rain, in the mud, but we are still doing medicine. So looking at what are core quality measures and where do these standards happen to come from? There are a number of agencies, professional associations, governing bodies that establish what does quality look like in EMS specifically. We can't directly translate
measures from in-hospital environments, from acute care environments directly into EMS, because EMS is very different, as we all know. And so we have to adapt those kinds of measures to ensure that what we are doing is we are providing quality care to the highest standards for our patient populations, but doing so in a way that actually works for EMS. These are a few of the NEMSQA measures. That's the National EMS Quality Alliance. It's a professional association. They do a lot of work when it comes to how do we measure care in EMS. For example, Airway 01, successful advanced airway placement on a first attempt where the patient does not experience hypoxia or hypotension. That is what we call an outcome measure. That is a patient-centric outcome measure where we grade ourselves on our performance of being able to accomplish that level of care for a patient. When we look at Safety 01, that is a process measure. Safety 01 is a percentage of EMS responses where we're not, blazing lights and sirens. That's a process measure. It's a small piece of the overall outcome of trying to make sure that we are safe when we are responding to calls. We are not unnecessarily putting the populations at risk for our providers and for the community that we serve by using lights and sirens when they're not necessary. So we have those different kinds of measures that we then kind of lump together. Again, credit to GMR Medicine, but this is all of global medical response data for the metric of assessing a capillary blood glucose level in patients with altered mental status for the year 2025, and it actually bridges over into 2024 as well. So we initiated a large quality improvement project when it came to how are we looking at this? How are we documenting the care that we're providing? And then we also said, how high can it go? As you can see, the blue line is the one that is actually showing you what is the level of, how many patients were actually assessed for capillary blood glucose. And that we first saw, we're like, oh, 58%. Is that good enough? That's a question we have to answer. In the quality world, there is almost never a time where we are going to meet 100%. And we have to be okay with that because there will always be exceptions to the rule. EMS is too highly dynamic to get to 100%. So we then have to judge what is good enough. How far can we improve this? And so we had an entire nation of GMR providers, right around 39,000 providers, involved in this quality improvement project to try and understand, to measure, to understand how we document, and then what actually is occurring out there on the streets, and bring all of that into alignment. So that way we can better understand the care that we are providing on a process measure, just one piece, of ensuring that patients with hypoglycemia are assessed, recognized, and treated. Now, when we married this data through the ESO collaborative to patient outcomes, we were monitoring that piece. And what we found was right as we crested 78%, the outcome data for patients that were diagnosed in hospital as having a hypo or hyperglycemia ICD-10 related code, EMS contact was assessing blood sugar in that patient population 94% of the time. So when we ask ourselves, is 79% good enough? Well, it's pretty good. We're not there yet. So we're not done here. We want to get closer, but we understand there will always be fallouts. We're never going to see 100%, and that's okay. There will always be the exceptions. It will be the equipment failure. It will be the patient who's allergic to aspirin, and that's why we can't, they have a true allergy to aspirin and anaphylactic type reaction, so we don't give that aspirin to that STEMI patient. One of those measures are, we're never going to get to 100%. The only time that's ever going to happen is on day one, the very first call, if we did it right. Other than that, we're never going to see 100%. So what we have to do is we have to establish what is good enough. This is a picture of the quality improvement poster from the National Association of EMS Physicians annual meeting this year. This was the presented work on this quality improvement project. The slides will be made available, so if you really want to get nerdy into the quality things and understand the graphs and stuff, there will be time for that. But I just kind of wanted to put that out there and say this is the evidence-based science that contributes to the establishment of the measures that we have in EMS. want to talk a little bit about clinical bundles. This is something that's very familiar in the in-hospital environment and in the acute care environments, primary care, all of those kinds of things. There's bundles of care. For EMS, this stuff is a bit more new to us, though we may recognize it directly from our protocols, right? All of our measures, our protocols are written in evidence-based science, and so our measures are very much going to align with what is in our protocols. And what we need to do is we need to understand how those things translate. So the bundle of care that I want to look at here is the quality improvement project that we are initiating for 2026. I was just on the launch meeting before I came in here. And so we are looking at the stroke bundle of care. What you see here are many lines and all of these kinds of things. And these are different elements of what is great stroke care that is centered on producing patient outcomes that are better. By looking to improve these different process measures, we call all of these things together a bundle. So we are looking at, did a patient receive a pre-hospital stroke assessment, BFAS, CSTAT, whatever, Cincinnati, because very large company, they're looking at whatever region is using whatever, required stroke assessment in their region. So all of those fit into that bucket. Was a blood glucose assessed for this patient population? Was the hospital pre-notified of a code stroke? Was the patient transported to a designated stroke center? And was the last known well time documented? And then how was our scene time? You'll notice that purple line happens to be the bottom one. Scene times are actually one of those things that we are working to understand as a measure. When we put these things all together, this is what we see. So this is the stroke bundle of care. It's a combination of all of those measures and basically our overall kind of grade for how are we doing in treating this patient population. When we do improvement work, we look at each individual process and we look at, okay, where do we have the most room for improvement? As you can see, we're gonna start taking a look at that bottom line when it comes to our on-scene times and exactly how is that measured. How we measure things is exquisitely important. Is that measure from when the initial first responding agency arrived on scene? So that was the fire department. And then the ambulance got there later, and that's why the scene time was longer? Or was it measured from when the ambulance arrived? Or was it measured from at patient side time? All of those nuances do matter. And what we're working to understand right now in EMS is how exactly is the best way to measure that? And we're getting a lot of feedback in the clinical environment on these different bundles of care, on these different initiatives. And it's sometimes difficult to understand because we can get some mixed messages when they're saying, hey, we need you to document that blood glucose. We need you to document these kinds of things. And you can muddy it up with, but why? What is the purpose? What box do I need to check in my documentation? And then we forget the overarching why. And it is because we are working to advance the science of EMS to better understand what we do, how we do it, and how we can do it better. Here we have STEMI management, our STEMI bundle of care for 2026 with Global Medical Response, looking at hospital pre-notifications for recognized STEMIs, being transported to STEMI designated hospitals, 12 lead acquisition at any time during EMS care, and aspirin administration. Looking at these where we see an area for improvement, that fun pink line there down towards the bottom. And we're marrying this data with outcomes from the ESO Collaborative. A little bit of information, the ESO Collaborative is 3,000 agencies contributing information to a giant data pool that we can do, and we can say, okay, here's all of this data. Let's look at the top 10% of performing agencies, and let's see if we are on par with that. Because we understand 100% is not attainable. But when we're trying to figure out what is great care, what does that percentage look like? It's not that traditional, oh, I'm shooting for 90 to 100% because I want that A. We understand there will be patients allergic to aspirin. There will be patients who had a cardiac arrest and we don't have the mechanism to give them oral aspirin. But then we need to look into that patient population and we need to say, okay, well, does it make sense to offer an alternative route? Do we have enough patients experiencing cardiac arrest with a recognized STEMI? We're able to get ROSC and do those things. Maybe we need to look at alternative methods of administration that are not oral for aspirin. And we're working to understand those things now. So we ask ourselves, 79%, is that good enough? Maybe, but we don't have the answer yet. For every quality improvement initiative, what we are working to do is establish what is that benchmark in EMS? What does that look like? This is just a view of the ESO data collaborative. I wanted to kind of include this in the slides and just touch on these points. This is the mission lifeline criteria for stroke screening performed in the field and documented for code stroke patients. This is actually for patients that were transported by an EMS agency that were later diagnosed with a stroke in the hospital. It doesn't matter whether that was ischemic or hemorrhagic or any of those kinds of things. This includes almost 17,000 records for the year 2025. 60% of those patients were documented to have had a pre-hospital stroke screen. So is 79% good enough? This is the top 10% of performing agencies in the United States. Well, maybe. But we need to do work here, and we need to do work in this space to understand. Why are the top 10 performing agencies contributing to the collaborative performing at 60%? Is it a documentation error? Is it an unrecognized stroke screen? Is it a custom stroke screen that is not well known and therefore not measured? Whatever those things happen to be, those are the things that we're looking at to align our processes and speak the same language and be able to compare not just apples to apples, but Granny Smith apples to Granny Smith apples across the country. This is now possible because we have the ability to contribute data to NEMSIS and, the obligation. There's that piece too. Everybody loves their drop downs in EMS documentation. But what it does do is it allows us to really do great science. Here we're looking at documentation of last known well for patients with suspected stroke. Again, this is that ESO collaborative data across 3,000 agencies. 86% of the time we're documenting last known well time. So that information is getting documented with the assumption that it's also getting communicated. And then the hospital folk can actually assess, okay, this is the time frame from onset that we can go off of, and that contributes to that patient's overall treatment and care. Pre-arrival notification for suspected stroke across the collaborative, 82%. Is 82% good enough? We're working on that. So what can we do? We can do process improvement measures, and what we can do as providers, as clinicians, is we can use the available best practice out there, and we can say, you know what, we know that when we do things like assign team roles on cardiac arrest, on stroke patients, or on any of these, higher acuity, more sick calls, we can assign roles or pre-assign roles while we're en route. And that helps improve efficiencies on scene that can do things like improve our on-scene times for our stroke patients. How good can it get? We don't know. We'll figure that out. We'll get there. Hopefully, I'll be back next year and telling you how that went. But that's what we're looking at. What else can we do? Scene timers. Most people have one of these fun things in their pocket. If you're like me, I have a couple of them, and usually they're in my pocket at all times when I'm working. So I can tell Google, Siri, whatever it is, I can give a verbal command to set a 10-minute timer. And so that thing starts dinging at me. It was one of my practices whenever I was going to a trauma scene, when I knew I need to have a 10-minute on scene time. That's my goal, my process measure. I need something to help me cognitively offload that task. I need some kind of a reminder. One thing that we have to understand and we have to be good with is that we are all human, and cognitive load can really affect our overall performance. We know this. We have demonstrated it time and time again throughout many quality improvement projects that cognitive offloading when we are in stressful situations can absolutely help, and it serves to improve outcomes. Another thing we can do is deliver that pre-notification early. When we're assigning those team roles, we get there, we can say, hey, if we do find a stroke or we do find a STEMI on this, it is going to be your job to make that phone call, hop on the radio, whatever it happens to be, and you can pre-plan what that notification looks like to be complementary to your system. and make sure that that person, when they arrive, that team member, they know exactly what to do. Consider things like memory tools. You can have, the cards. When in my past systems, we've had cards that were attached to a cardiac monitor that gave them kind of the scripted lines of this is the information you're doing. And we had people who were just first aid and CPR trained. I come from a rural environment for my most recent EMS experience in the field. We had, people who were just CPR trained making the phone call for a STEMI activation. It doesn't have to be the paramedic making the phone call necessarily. The initial notification in our system was just, hey, we just need to get them notified. They need to know what we think it is and how far away we are. And then we'll call back and we'll follow up with additional details and information. So anybody could make that phone call. And so we made an endeavor to ensure that no matter who was on that scene, we could make sure that they had what they needed to make a phone call. Because in talking with our people, the reason they weren't comfortable making the phone calls, they didn't know what to say. That's something easy we can fix with a memory tool or with a job aid. Those are wonderful things to implement. And then the other thing would be, I would encourage you to discover, ask your leadership about what are we doing in the space of quality? What are we working on? What are our goals? Do we have a committee already set up for this? Is there a way that I can get involved? Quality improvement work is done not by the people who, like me now, sit in an office. I have never worked in the field at my new operation. I am not field qualified yet. It's on the to-do list. I don't work in the field in my operation. And I tell my folks that we know what that means. I should never be the decision maker for how we accomplish the goal that we are shooting for. I rely upon my people to tell me, hey, I think this would work. I think a memory tool would be perfect to help us do this. My job is to bring them the information and to involve them in the conversation and be like, hey, what if we tried this? What if we tried that? What if we, used timers? Do you have the tools that you need? Maybe you don't have the resources that you need on a particular call type in order to do better when it comes to getting off that scene. Those are the conversations we need to have with our line staff because those decisions are made in collaboration with them so we can make system changes to ensure that we have a sustainable method for improvement. And once we start reaching those goals, we can maintain them. For leaders, every, at least EMS transporting agency in the state of Oregon has some form of a quality management program. It's part of our licensure with the state. We have something, every agency does. Every agency has people who are working on different projects. I encourage you to get involved and to understand how those can be married with other initiatives that you have in your departments. When you hear providers saying, you know what, I just hate the way that the ambulance is organized. What I need is always way over there. Okay, how's that affecting your care? We can marry these initiatives together and we can collaborate and work on these things because small tests of change can have very large impacts. The implementation of a memory tool, moving a piece of equipment, or changing how it's stored can accomplish multiple different endeavors, especially when it is driven from the providers that are doing the work. I encourage you to advocate. Bring forth these measures in your everyday conversations. Ask the questions of the clinicians and be like, okay, well, tell me about that call. What was hard about that call? Do you think you did well? Do you think we met our goals? What kind of feedback are you looking for on calls like this? How can we better support you in getting better on these calls or feeling more comfortable? How can we better support? And then let's keep track of those things. And that way we can go back and we can say, you know what, I've talked to 10 different providers and they all said, we need to move this piece of equipment or we need a different equipment storage bag. So that way we can then perform better on these things. And when we do this in this way, it makes the changes that we make evidence-based, makes them reliable. And then we track and see, did that actually improve things? Or do we need to try something differently? One of the best things about quality improvement that I love is it is absolutely okay to fail. as long as you learn something. Try again, feel better next time. So please, please, please collaborate, involve everybody from your CEOs or your fire chiefs or district boards, all the way down to your line providers, or in my most, recent operation before here, your first aid and CPR trained. I've got some references and some credit. Again, these things will be available. And so I just want to leave a few minutes for any questions.
Sorry.
Yeah.
I have a question about the way that data is collected for NEMSIS and specifically how run sheets get transferred between EMS and the emergency department and put into the chart. One of the things that we see at St. Vincent's a lot is that the run sheet didn't somehow make it into the record. And I wonder how that affects the way that you track data with NEMSIS and what's included there.
So the data transferred is different by system. We're all collectively moving towards HDEs, health data exchanges, that will help so much with that, especially in partnership with data for our hospital partners and for EMS providers to be able to see outcomes of their patients. I know nobody in here has ever been wondering whatever happened to that one patient and was I right? That's not something we do in EMS, but for different systems, it's very different. My understanding of specifically for Providence is that we still operate off of a fax server. So an EMS person hits, complete, lock, send on their chart, marking it as final. And what that does is it goes to a fax server that then sends a paper fax to the medical records department of a hospital. And the medical records people receive those faxes, they scan those things in and they go in and attach those things to a patient's chart. Unfortunately, fax technology is a little limited in some ways. The fax machine could be out of paper, any of those kinds of pieces. So that can inhibit the data transfer to our hospital partners. When we have data connected systems, so when we have HDEs or when we have linkages that are built in, those are very expensive endeavors, by the way, which is why they do take a while to implement. But once we have those linkages, which I believe like OHSU should go live next month, by the way, for HDE with at least for American Medical Response in the areas, the Tri-County area fire departments that are on ESO. We will actually have outcome data coming from OHSU. And when we transfer care, even if we mark our PCR as a draft in EMS, it'll upload into Epic and the providers can see it right there, thus improving continuity of care. Because maybe I forgot to mention the patient did in fact get aspirin or something along those lines. What these complications and these HDEs don't do is inhibit data transfer to NEMSIS. What happens with ePCR data from charts in EMS is those are electronically transmitted to the state. For Oregon State, that's how our structure is. It is automatically uploaded to the state data repository. The state collects more data than does NEMSIS, which is standard across the United States. But all of that stuff gets uploaded to the state data repository, and then from the state, it is then validated. It is scored in essence, and records can be rejected for being insufficient or not, or they're accepted, and then the data flows directly into NEMSIS. That's a pretty standard process across the United States. I believe it is the most common. But what we don't see is, because we have, we have all of our data analysts working very hard and tirelessly making sure that all of our records are successfully transmitted to all of the places that we are required to submit our data.
Thank you.
Yeah, absolutely. Yes.
The only connection is the faxing. It's like an extra step after you close your chart and you sync it. And oftentimes they error out, like the faxing process won't go through, and unless you check it, you won't know. So that would probably be affecting the ability of you guys to.
That makes sense to me. It's been kind of a mystery because I remember when I was an ER nurse, we get these papers from EMS and I didn't necessarily understand at the time that they were important. So I contributed, I think, during my tenure as an ER nurse to the loss of EMS records sometimes. I'm tidying up. But yeah, so the fax process makes a lot of sense for why things would be missing as often as they are. That's something we should look into on our end and see if we can help optimize it and make it easier for y'all.
And I do know that depends on your software platforms. ImageTrend, if you're using ImageTrend, they have Hospital Hub, which is an electronic manner by which hospitals can access patient information out of that have been transported by an EMS agency. And then ESO has Patient Tracker. So should a fax fail or any of those kinds of things, I encourage, hospital agencies to reach out to either ESO, to ImageTrend, whatever their, their EMS agencies are using, and get those things set up. I know for AMR, we have worked with all of the Tri-County hospitals to be able to get them access to Patient Tracker specifically. So should they have any access at any time or any need to access a record at any time, or a fax server should fail or something, they can immediately log in and they can see it. It's something that is managed by the hospital, so they can choose, who gets access. Is it charge nurses? Is it every nurse or anything like that? But those are available across most EMS platforms. Certainly, I know for a fact ESO and ImageTrend.
For a charge?
Yeah.
Cost money
No.
to connect?
No.
Okay. Just
It's
curious.
just the administrative costs of managing it.
Yeah. Okay.
But yeah, there
Awesome.
actually is no charge to the hospital.
Anything online there? Questions? All right. Thank you so much.
Absolutely. Thank you.
I would like to welcome, I guess we could share this. Our next speaker, Dr. Amit Kansara, and I think you saw a little bit of his picture in the telerobot on Emily's lecture. Amit has been with us, Amit Kansara, sorry, Dr. Kansara has been with us as a stroke program medical director. He joined us, I think, a couple years after me, 2 years, 1 year. He is also a Fellowship of American Heart Association and sits on the local board for American Heart and American Stroke Association. He believes in the advancement of management of neurological disease, future opportunities to find new treatments for neurological diseases have made the current era of neurology practice very exciting. So great discussions that our team has had in the last few days with Dr. Kansara also and the guidelines that have come out. Things he finds it challenging and very rewarding at the same time. He appreciates acute stroke care and stroke prevention. Has involved so much that we can see a large majority attain independent living and quality of life after their stroke. And I just wanted to welcome Dr. Kansara. Thank you so much for sharing some stroke case studies with us. So if you want to use the mouse to point.
Okay. Thank you, Diane, and thank you, Cardiology and Neuro Institute, for putting this together. It's a wonderful conference. Every year we get to do this, and every year there is something new to share, and appreciate all of you attending. This is our picture from the heart and stroke work from last year. I don't have any conflict of interest. We are going to talk about ischemic stroke, some concepts. So I'll clarify the core and penumbra. We'll talk about thrombolytic therapy, what we use and what are the advancements in thrombolytic therapy use. Some updating guidelines. So American Stroke Association came out with a new guideline just 2 weeks ago, and it is kind of practice changing updates. So we'll talk about that very briefly. How we make the thrombolytic decision making, and also mainly we'll talk about some case stroke studies and what happens after we get the patient from EMS. First, some anatomy of the blood vessels. So we'll use this mouse, and I hope like online people can see it. This is common carotid artery. Okay, common carotid artery. And then it becomes internal carotid artery, external carotid artery. Internal carotid artery goes into the brain. It divides into middle cerebral artery and anterior cerebral artery. On the back side, 2 vertebral arteries. Again, 2 vertebral arteries, they combine to form basilar artery. And from basilar artery, you can see there are 2 posterior cerebral arteries. You can see small branches from the basilar artery. It supplies brainstem. And there are other branches which supplies the cerebellum. And this is just a diagram which area of the brain is supplied by different arteries. So I won't go into detail of that, but this is the basic blood vessel anatomy of the brain. It will be helpful when we discuss case studies. The concept of penumbra, and I think this has revolutionized stroke treatment in last, I would say, 10 to 15 years. Every minute counts. When we talk about stroke, we say that every minute counts, and every minute brain loses 1.9 million brain cells without blood supply. Heart and brain is a little different in that way. The threshold for brain cells to die without blood supply is pretty low. So without blood supply, you can start seeing the changes. And when we talk about the concept of penumbra, which has changed some treatment options over the last few years. So if you see the image here, brain damage starts happening within first 2 hours. So there is core area of stroke, what we call core infarct or core stroke, the red area. But surround that area, there is a big area. And if you see in this CAT scan image, the yellow area where you can see this area of penumbra, where there is slight decrease in cerebral blood flow, but your volume is still there. Means blood is reaching there, but what we call mean transit time, it is longer. So that area is a penumbra area, and we want to save that area by treatment, either with IV thrombolytics or with thrombectomy, mechanical thrombectomy to remove the clot. And the image, these two images, they are showing this CT perfusion study. On the right side here, the pink area, it is the area where cerebral blood flow is less than 30%. So when it goes below that, usually this part of the brain, they die down without the blood supply. And this part, even if you do thrombectomy or IV thrombolytics, most of the times this part does not recover. But the green part, where we feel that beyond that core area, there is extended area beyond that core area where it is the area of penumbra. So if you do some intervention, either with thrombolytics or thrombectomy, this area you can still save. So there's lots of research, so many trials came out in last few years, and we'll talk about a little bit of those things too. So again, the time is brain, the concept that we know for so many years. This is a very well-known paper in stroke world, highly quoted, but all the thousands of patients data here. So after usually 5 hours, we used to know that any benefit from thrombolytic therapy usually goes down significantly, and then the risk of bleeding is way higher. So that's why the window of treatment used to be up to 4.5 hours. But every brain is different. Their collateral circulation is different. So not to stroke, they behave same way. And we are learning about that concept, particularly with the CT perfusion or MR perfusion studies. So time is brain, faster treatment leads to better outcome. We know that we do not want to delay the treatment, but can we find the subset of patients with this advanced imaging where you can still provide treatment beyond 4.5 hours with thrombolytics, with thrombectomy? And we'll talk about that. I think Emily talked about this algorithm very well, so I'm not going to go into detail, but yesterday I asked just ChatGPT to give me a picture of EMS picking up the patient and last known well time. So obviously AI will do so many things, but we all know that the bedside need, the human touch, I don't think so it will replace. And then we are always going to be very important part of this journey in stroke patient's life, or any patient's life. Yeah, so it's a cute picture, so I just kept it there. We'll talk about concept of disabling stroke. So at the bedside, when you see the patient or when you go to pick up the patient, the important things that we want to know is last known well time, whether they are on any blood thinner. And blood thinner, when we keep talking about blood thinner, I think we also want to know whether it is just aspirin, Plavix, or nowadays you will see Brilinta too, or ticagrelor. But we also want to know whether they are blood thinner or anticoagulation. So they are on this newer anticoagulation or warfarin, Eliquis, Pradaxa, Xarelto. So we want to know about that. And we'll talk about concept of disabling and non-disabling stroke. It is important, and then there are some finer points about that. So the basic thing is, when we receive the patient, we want to get the CT scan as soon as possible, right? Within 5 to 10 minutes. We want to get we want to know their blood sugar. Once we get the CAT scan, and based on the history and their medication list, in most of the cases, we can make the call whether we want to give IV tenecteplase or not. We do not want to wait for CT angio, although part of the protocol is you do CT angio all in the same sequence. But sometimes we get time between CT, angio where we can make the call and we can give IV thrombolysis within 30 minutes. That's the goal, door to needle time within 30 minutes. And we want to achieve that in more than 50% patients. So all comprehensive stroke center, good stroke centers, they should achieve that goal. So this is important slide, and this is a part of new guideline that just came out. I would emphasize on things that is written over here. The following deficit may not be clearly disabling in an individual patient. So sometimes we see code strokes and their volume is also going up based on the time window that is expanded. But there are certain things where there is enough data when symptoms are so mild, and if they are not disabling for the patient, you have to talk to the patient to determine they are disabling or not. In your mind, it could be very mild, but still you have to talk to the patient and family to determine that. But if they have just mild sensory loss on one side or just part of the body, it is most of the times it is non-disabling. Most of the times we are not going to treat those patients with IV thrombolytics. So when NI stroke scale is very low, usually they are saying 0 to 5, but when we know from the data from multiple trials, when it is 3 or less, and the symptoms are non-disabling, usually dual antiplatelet treatment, they do as good as thrombolytics or even better, and there is no risk of significant bleeding. So mild hemisensory loss, sometimes subtle weakness in the hand, or just the mild dysmetria or subtle slurred speech, isolated facial droop in an old age patient, they are not disabling symptoms. And with the low NI stroke scale, most of the times they would qualify in the category of dual antiplatelet therapy rather than IV thrombolytics. But again, we have to make that call on patient by patient basis. This is just the 4 major highlight of the changes. The change is like 100-page document that they came out with. And then one of the main thing is tenecteplase. It is the main, now it is class 1A recommendation. That means it's a strong recommendation. I think in Tri-County here, every hospital and big system, we all use tenecteplase. Still, there are some small hospitals in country, they are still with alteplase, but now tenecteplase is a part of the guideline. Previously, it was kind of 2A and 2B recommendation, but now it's a part of guideline. Another big change is extended time window for treatment from until now, we used to treat patients with IV thrombolysis up to 4.5 hours. So when you take the first call and when you give us the last known well time, if it is beyond 4.5 hours, in most cases, we know that unless they are wake-up stroke, we know that they are not going to qualify for IV thrombolysis. Now, in this guideline, we have class 2A recommendation. That means benefit is more than harm. It's not class 1A recommendation, which is the strongest, but 2A is still very strong recommendation where based on the advanced imaging, you can choose certain patients who would still benefit with thrombolysis. So that is the main change. And large core stroke. So when CT scan has some early changes of stroke, we count certain things. We count aspect score on the CT scan. And we feel that the significant amount of stroke is already happened on CAT scan, then sometimes we did not used to send those patients for thrombectomy because we know that already damage has happened. They are not going to benefit significantly. But there are subset of patients, they can still benefit from thrombectomy or late thrombectomy in this class. So that is also a new recommendation that even though stroke has already started happening on a CT scan, you can see it, but there is subset of patient you can still send for not thrombolytics. I'm talking about thrombectomy. In a late window, and they would still benefit. So that is another change, and that will change some practices, some resource utilization across the nation, I think. And then it's still too early to see how it will go, but it will change some practices, and it's good to know these things. Based on this many trials, they extended the window, what I talked about, but to consider the patient beyond 4.5 hours for treatment with IV thrombolysis, we need either CT perfusion study or we need MRI or MRI perfusion study. And there are specific criteria. I have a couple of cases that we can discuss that it has to match those criteria. There has to be some penumbra that I discuss on CT perfusion study or on MR perfusion. There are specific criteria. It has to be there to treat the patient up to 9 hours. And it's not like every patient would qualify, but patient when they are in good baseline functional status, they are mobile, their baseline modified Rankin scale is 0 to 1. We are going to consider on case-by-case basis that, okay, which patient would qualify for this extended time window. Some contraindication has also changed. So initial guideline had this contraindication that has been going since 1996. But some new changes that happened in this guideline, particularly patient with small microbleeds on MRI brain, we treat them if we have MRI brain. It's not like we are going to get MRI brain when we are making the treatment decision, but if we know that they have microbleeds in the past on MRI brain, if it is less than 10, we can still treat them. It's not a frank ICH I'm talking about. Unruptured intracranial aneurysm, if it is less than 10 millimeter, we consider them with treating with IV thrombolysis. Past stroke in last 3 months used to be one of the absolute contraindication. That has changed. Now we can treat those patients if stroke is beyond 3-4 weeks. It's not a large stroke. We can still consider treating them. Patient with Moyamoya disease, stroke mimics, sickle cell disease. They were all like very soft indication. Now they are saying very clearly in this guideline that benefit is more than the harm, and you can consider treatment with IV thrombolysis. And then another big change is they are also, although we treat as adult neurologists, I treat patient beyond 18 years, but the other change that came up is above the age of 18 months, up to 18 years, they are making strong recommendation that IV thrombolysis may be beneficial in this group of patients too. So hospital, they have to have a system of care and some established criteria how they are going to deal with this patient population. So now it's all going to be cases. I have 10 ischemic stroke cases and a couple of ICH cases. Some of the cases I was involved, some of the cases are from my colleagues. So I'll start with this case. 64-year-old mechanic. He comes in with acute onset of mild weakness and then right hand grip, mainly with the first finger and the thumb, and he's not able to do opposition. He's not able to make a very strong hand grip. And his mechanic, he drove to ED from his work. I remember this case, I think it was 3 to 4 years ago. And that's it, nothing else. So there was not even drift or anything like that. So what do I call it, disabling or non-disabling? And his mechanic works with his right hand. So in his case, we had a long discussion, I remember, and he talked about like it could be peripheral nerve injury, but so unusual that you do not have any wrist pain, no neck pain. There is no injury recently to arm or the neck, and very unusual. And he had good wrist flexion and extension. So usually with the radial nerve injury, you see wrist drop. So he did not have that. So there was no other etiology to explain, and that was his dominant hand. So ultimately, after good discussion, we decided to treat this patient. This was his MRI. So you can see he had a small stroke in what we call hand knob area. So this is the topographical map of the brain where hand is small, but it occupies one of the largest area in the brain in this parietal area. And this hand knob area, if you have a small stroke, then you could have those kind of weaknesses, either the hand grip weakness or your shoulder is fine, your elbow is fine, but just few fingers or hand grip weakness. And this patient became normal in 12 hours and he was discharged the next day with no deficit. Overall, because of dominant hand, I treated him. He was still like 64 and in good shape and he was working. I would not treat somebody who is very old age and significant comorbidities with this much deficit. And again, like some of the time, these patients, they improve with just dual antiplatelet therapy. And then that's why we had good discussion about what are the potential differential diagnosis. And when the stroke is this small, and if they don't have an issue of blood pressure and then no other like brain issue, they are not of very old age, then usually the bleeding complication rate is very, very low. So that gives you confidence. In stroke mimics patient also, you can treat with IV thrombolytics and bleeding complication rate is less than 0.5%. So this patient got benefit of this treatment. Another case, 71-year-old male with hypertension and hyperlipidemia. Came with speech difficulty and right facial droop. And daughter called 911. She saw him last prior to bedtime. He came early in the morning. EMS evaluated the patient, found to have aphasia, able to follow some simple command, but unable to form full sentences. And last known well time was night before, 2200. He did not have as such contraindication other than the time window was off, no other contraindication. This was his CT scan head, which is completely normal. Just to give you some idea of CT scan head, So when we see CT head, the main function of CT head in early phase is to rule out bleeding. So in this patient did not have any bleeding. The bleeding should show up as wide hyperdense area. And then I have a couple of examples of that. But this is a normal. Another thing is we see sometimes subacute stroke changes. So these are the sulci, which is all normal. Although you see slight difference, but this is normal because the cut is like that, that you are seeing slight difference. But on the both side, we are not seeing any early changes. If there is early stroke, you will see this kind of black area in the brain parenchyma, and we are not seeing in any part of the brain. This is ventricle. This is calcification in choroid plexus in the ventricle. So this is all like normal finding. This is not bleeding. So this is a normal CT head, which we would expect in patient. But this also gives us the clue that this patient probably last known normal was night before and came early morning. We don't know when stroke happened, right? Between night and early morning, and patient has normal CT scan. Usually CT scan starts showing changes of early stroke after, I would say, 6 to 10 hours. Every patient is different, but you don't see the changes that gives you some hope that, okay, still early damage has not happened. Anyway, story changes in this patient, but telestroke physician was consulted by AD. Last known well was more than 4.5 hours. I'm talking about this happened before this new guideline came out. CT head was negative. So they decided not to give IV thrombolysis, but then patient girlfriend arrived, reported having spoken to the patient around 5 a.m. And he was normal at that time. So again, telestroke physician was reconsulted, NIH scale was 6. There was no contraindication to IV thrombolysis. So patient was appropriately given IV thrombolysis. And this was the CT angiogram. So if you see this CT angiogram, this is coronal section. Patient is looking at us, and then this is like coronal section, and this is left MCA. And left MCA M2 branch, if you follow that in the distal M2 branch, it is kind of flow is stopped here. So it showed the distal M2 occlusion or middle cerebral artery M2 branch occlusion, which goes with the symptoms of aphasia, right facial droop. Now, this is too distal. Most of the times this patient would not go for thrombectomy. And then patient was transferred, but he was not considered for thrombectomy because the block is too distal, and to reach to that small branch with wire is also risky. And then current guideline does not endorse doing mid to distal M2 thrombectomies. So M1 is fine, proximal M2, dominant M2 is fine, but the mid to distal M2, it does not endorse. So this patient in 90 days, his NIH scale was 2. You can see some stroke, the hypodensity that I was talking about. So now from initial normal CAT scan, you can see in this M2 area in the frontoparietal area, you can start seeing some hypodensity here. And his 90-day outcome with an NIH scale of 2, and he had some expressive aphasia and some dysarthria. But I think this, I don't know the ultimate outcome, but usually this patient with mild speech deficit, they can continue to improve up to 9 to 12 months, and they improve well over time. So this is the concept of wake-up stroke presentation. So from time-based thrombolysis, we used to have 4.5 hours. Now we are talking about 9 hours based on what? So if we get stat MRI in some of these patients, I'll just give you the explanation of this image. In the first image here, DWI, it is diffusion weighted images. So when we do MRI, this is how stroke look like. This white, what we in MRI, we use the term hyper intense. This is how it should look like. And there is another image, flare. After few hours, you would start seeing the same changes on this flare sequence. If you don't have those changes, corresponding changes in the same area, you can consider that this stroke happened in last 3 to 4 hours. And that's why we are not seeing these changes. That means we can see some cytotoxic edema. We can see some damage has started happening, but it is still reversible. So if we do this kind of MRI, where you can see what we call DWI flare mismatch, they are still within window for thrombolytics. And then this patient can benefit with thrombolytic therapy. C and D, they are the example where you can see DWI here, changes in the left basal ganglia. And then the same changes on the flare sequence. So sometimes when we see this wake-up stroke presentation or after 4.5 hours patient comes in, we may ask for stat MRI, and this is what we are looking for in those patients. If we see this mismatch, and if we feel that patient would benefit, we can still go after IV thrombolytics after 4.5 hours, or in wake-up stroke patients with last known normal last 9, and they wake up with stroke symptoms, we can consider the treatment. So the practical consideration for us is, okay, 4.5 hour window, yes, we want to know that, but now we can also consider extending up to 9 hours. We want to know the last known well time, as well as you can get or family can provide us. Sometimes the factor causing delay in treatment after patient arrives to us is you're not able to reach the family member, we don't have right phone number, or they are in transit and you are not able to reach them, or a patient is coming from the facility and there is no good history or good phone number to talk to. So I think while you're bringing the patient, if you can get that reliable information, it would be very, very helpful to us. And also, sometimes we just don't have any records in EMR, or there are no medication history or nothing, or nobody to talk to, then we can't verify if there is any contraindication or not. In some cases, we can still do thrombolysis with 2 physician consent. It's not a written consent, it's a verbal consent. You talk to the ER physician if they have significant deficit and you feel that benefit is more than the harm, then you can provide the treatment with 2 physician verbal consent in those cases. I'm changing the topic a little bit. I think this is the common thing that you would encounter when you get some calls and you see the patient. Acute dizziness is so common. So many post-stroke, they come with acute dizziness, right? And then what are the things that we look for? What are the things that we can differentiate or try to differentiate between peripheral vertigo and then central vertigo or stroke? So sudden onset of dizziness or vertigo, nausea or vomiting, gait instability, that is acute vestibular syndrome, right? And then it's so hard to determine it is peripheral vertigo or ischemic stroke. And there are some clues that we can find on examination that can help us. This is the posterior fossa anatomy. Won't go in too much detail, but just to give you an idea, this is cerebellum, brainstem. This is the pontine part of the brainstem. Again, 2 vertebral arteries forms the basilar artery, divides into PCA. There are some small branches. So posterior fossa stroke can happen from any of these branches occlusion, right? It can be a big stroke with basilar artery occlusion, or it can be a very small stroke when you have just a small branch occlusion with atherosclerotic plaque buildup. And the presentation could be different with every branch occlusion. And that's why I think it's good to know the anatomy in this kind of situation, and then how we are going to treat those patients can be a little different based on where the blockage is. So another case, 71-year-old male, he woke up normal, but suddenly developed vertigo, gait instability, lost balance, and fell back down on a couch. Could not walk due to vertigo, had some nausea and vomiting, and family helped him to the car and brought him to ED. There was no weakness. So when we see patient on gurney, they are fine. There is no weakness, speech is normal. There are no significant sensory deficit or visual change. So last known well in this patient was 3 hours prior to arrival. Stroke scale was 0. And then although stroke scale was 0, now in this kind of situation, we try to get some examination with gait. They are rushed to the CT scan, but between CT angiogram, if we have a time, or if patient had tried to walk before coming to the ER, we try to get that story either from family or ER doctor or from EMS colleagues. That, okay, did you see the patient walk or try to make patient walk? And then what was the situation? Did they fall down? So this patient had severe truncal ataxia, could not stand up without assistance, and listing to the left side. Again, on CT scan, there are no changes. It is normal CT scan. Usually you look for the posterior fossa. You can see some hypodensity here, but this is normal, what we call sometimes chronic microvascular changes type hypodensity. It is not early stroke. And this patient was treated with IV thrombolysis, although NI stroke scale was 0, but the symptoms were disabling. And then there are no other explanation in this kind of situation that why somebody would have this kind of symptoms. And in CT angiogram, it also gives us the clue. There are no large vessel occlusion, but if you see the artery is partially blocked, the one of the branch, what we call pica branch, posterior inferior cerebral artery. So this patient would have lower cerebellar stroke, and we would see that in the next image. This is again close-up view of the blockage here. So CT angiogram can also give a clue to you that it is going to be posterior circulation stroke rather than peripheral vertigo. And this patient actually developed large left cerebellar stroke. So this kind of situation where patient looks benign on the gurney, but it could still be a large cerebellar stroke. And the issue with this kind of stroke, even with treatment, he developed this stroke and then this can swell. So cerebellar edema or cerebellar edema can happen in starts happening in 24 hours, but can happen and can maximize up to 3 to 5 days. The problem with this kind of stroke, it can compress the fourth ventricle, and if that gets blocked, the patient can develop hydrocephalus, and that's acute emergency. So even with treatment, this patient developed this kind of stroke. So this shows how we can determine differential diagnosis of central versus peripheral vertigo. I won't go into too much detail of those things. I would pay attention to if there are obvious cause, traumatic or toxic cause, usually we know. But let's say it's a spontaneous acute vestibular syndrome. How do you determine it's central versus peripheral? And then there are some clues I would discuss in next slide. Go to next slide. So with the central etiology, sometimes you would see significant nystagmus in all directions. With the peripheral vertigo or vestibular syndrome, the nystagmus is usually just what we call horizontal nystagmus, and they would not have all directional nystagmus. They would not have skewed deviation of the eye. Sometimes with the central vertigo or stroke, they can have a skewed deviation. And if you check their eyes, you cover one eye and you remove the hand, and you can see that both eyes are not aligned. That's a vertical skew deviation. And sometimes with peripheral vertigo, they have a saccades, the sudden movement, and their eyes come back. In the central vertigo, the saccades were not there. And this is called Hintz testing, and it is more than 95% sensitive and specific to determine peripheral versus central vertigo. But if they have some other things like significant nausea, vomiting, truncal ataxia, or if they have mild dysmetria along with these symptoms, probably they are going towards central cause for vertigo or stroke rather than peripheral vertigo. And then we can consider treatment in those kind of cases. Still, it is very hard. I think still in so many cases, if I go to bedside, I can't determine. I think if you put ENT specialist with multiple years of experience and neurospecialist, and still I would say that in 30–40% of cases, they would not be able to determine central or peripheral in early phase. It's hard. So the approach to see this patient and how you determine that whether they are going to be candidate for thrombolytic therapies, can they walk, right? All these symptoms on gurney, they look fine. But most of the peripheral vertigo patient, if you move their head suddenly or they change the position and immediately they become symptomatic. And then in central vertigo, with just a head movement, they are usually not symptomatic. They do not have significant increase in their symptoms, nausea, vomiting, or feeling of unsteadiness. It's usually shared decision-making when stroke scale is very low. You want to treat this patient, you want to see, okay, what is their age, what are their comorbidities, and you talk to the family and decide whether it is significant enough to treat or not treat. And so that's why it's a shared decision making. This patient I treated just few months ago. Patient woke up and walked normally to the restroom around 9:40. But while attempting to place his hearing aids, he experienced acute dizziness, imbalance, and describing sensation of leaning or falling persistently to the right side. Also noted some spinning sensation. Now he has this history of bilateral cerebellar and brainstem stroke, MRI proven in February 2025, and he completely improved from that. So did not have any residual ataxia or residual symptoms. So his stroke scale was 0. But in this patient, I remember I tried to, I stood him up and then immediately he was just listing to the one side. He was just falling. So you have to hold him and put him back. Otherwise, he was not symptomatic. There was no significant dizziness with head movement, nothing. So mainly it's gait ataxia, nothing else. After good discussion and luckily family was there, we decided to treat the patient. There were no contraindication. We treated him in 29 minutes, and this is his stroke. So he had this small right cerebellar stroke. He improved and he was discharged in 2 days. The problem with this kind of cases is you see the full spectrum. In so many cases, you just see small stroke, they improve, they go home. But also you see the other spectrum, the case that I showed you earlier, case number 3, where the same type of symptoms and they can develop big cerebral stroke. And that's why it's so important that you pay attention to these things and try to provide the best treatment that you can. Let's talk about acute unresponsiveness. If you get a field call that patient was normal and then witnessed to be normal, had sudden collapse, there was no trauma, no respiratory arrest, no cardiovascular impairment, and you find good pulse, clear history that there are no cardiac issue or there were no syncopal event, but patient just like became unresponsive out of nowhere and no seizure-like activity. You're going to check the ABCs, but what are the causes? And in this kind of situation, when you don't have any other explanation, you have to start thinking neurological cause. And then, so we'll talk about neurological cause, but other things that can cause sudden unresponsiveness or maybe acute on chronic unresponsiveness type situation, metabolic. If you have CO narcosis or carbon monoxide poisoning, even carbon dioxide retention in patient with significant sleep apnea. I have seen patients, they become unconscious or sometimes come with a flapping tremor and then you don't have a reason and you suspect this is sleep apnea and there is CO2 retention. And if you do blood gas and you find that, sometimes liver cirrhosis, ammonia toxicity, ammonia level can go up and then they can become unconscious. Sometimes it's pure functional. There is nothing going on. They have significant depression, psychiatric disorder, functional disorder, and then they are unresponsive. And then toxic causes. If you know or find some medication or overdose or some certain other things, they can become unresponsive. But in neurological causes, if they are completely unresponsive, things are, you need to rule out different kind of hemorrhages in the brain, right? Stroke, which can make patient unconscious. Either they are brainstem stroke. The main thing is top of the basilar clot that can knock you unconscious right away. So that you need to rule out. If they have bilateral large stroke, it can happen. Usually small stroke will not make you unconscious. And then very small stroke in certain part of the brainstem, which has the areas for consciousness, it can make you unconscious. Very rare. I've not seen many over the last 15 years of practice, but can happen theoretically. So another case, 76-year-old woman brought to St. Vincent by EMS with acute unresponsiveness found down by family, and last one well was 1 hour prior to arrival. TCS was 3, asymmetric pupil and no limb movement. Did not follow verbal command and intubated in the field. So sometimes we get this kind of history and there is no exam, right? And limited exam due to paralytic use, symmetric pupil. There was no contraindication to thrombolytic therapy. So this is the patient CAT scan, CT scan head. It gives us some clue. If you see this area, this is the top of the basilar artery. It is hyperdense, means there could be a thrombus. This is not CT angiogram. This is a CT scan without contrast. But you can see hyperdense top of the basilar artery here. That tells us that this could be basilar artery thrombus. So when you do CT angiogram in this patient, and yes, there is a thrombus. So this is the basilar artery, mid to top basilar artery. You can see clot blocking the artery and extending into right posterior cerebral artery. There is no left posterior cerebral artery, so that area is gone. So in this patient, there were no contraindication. Patient was treated with, I think, thrombolytics, and then patient was taken for thrombectomy. See, these are the picture for cerebral angiogram. So left vertebral artery dies going through now basilar artery, and there is the clot here. We are not seeing much flow, maybe slight flow in the right PCA, but there is no flow in posterior circulation. This is after the thrombectomy. There is complete restoration of flow. Now you can see basilar artery opened up. This is PCA, posterior cerebral artery. These are some cerebellar branches, superior cerebellar branch. So all the branches, they open up now. Good reconstruction rate. And then MRI showed just a small stroke in the left cerebellum. But overall, this patient in 90 days returned to baseline and had significant improvement. So this was a good outcome. Again, with the good reconstruction, still things can go bad, but this was a good outcome in this patient. Another case, 70-year-old male with prior stroke, TIA, history of AFib, not on anticoagulation, and came to PSV with change in vision, left side weakness, and decreased responsiveness. Last known well was 2 hours prior to arrival. EMS found patient lethargic, followed some command, but moving right side more than the left side. And patient had left facial droop withdraws to noxious stimuli, and stroke score was pretty high, 26. There was no absolute contraindication for thrombolytic therapy. If you see the CT scan here, we are seeing this hypodensity in the right temporal area, temporo-occipital area. Now, this could be subacute stroke or chronic stroke. Subacute means that happened between few hours to last few days, or chronic means it happened long time ago, and then we don't know when it happened if you find that on CT scan. But in this patient, so yeah, it was a chronic ischemic stroke in right occipital lobe. This is the CT angiogram. This is left vertebral artery. And in the left vertebral artery, you are not seeing like it is not completely opacified with the contrast. So when you see this kind of black dot in this area, it is a clot blocking the artery. So we had clear idea that what's going on with this patient. Treated with IV thrombolysis with tenecteplase. And sometimes when the clot is extending into the basilar artery, you do thrombectomy, but vertebral artery thrombectomy, when clot is partially occluding the artery, you try to put the wire through that. Sometimes you can dislodge the clot and it can create a problem rather than helping. So on case-by-case basis between neuro IR team and the stroke team, in this kind of cases, we make the call whether we should go for thrombectomy or not in these cases. And then with this patient, actually, so this is a chronic right occipital lobe stroke. This is the follow-up MRI, and you can see the stroke in bilateral thalamus. So this is the thalamus area. So patients still develop this. And when you see this kind of stroke in bilateral thalamic area, there is one particular artery. It is a rare kind of stroke. Patient can become very sleepy if they have this kind of stroke because thalamus has some sleep centers. If it is affected, you can become very sleepy. So there is artery of Percheron. It comes from the posterior cerebral artery. So although clot was in the left vertebral artery, ultimately clot had traveled through that to this artery, and it supplies, you can see two branch. It supplies to both sides and then supplies the thalamus. So if you have this kind of stroke, patient can become unconscious or less responsive. So in summary, when you see acute unresponsiveness, obviously you want to rule out hemorrhage by non-contrast CT. CT angiogram is must in this kind of cases. When you don't get any history or sometimes you get some history, you want to look at CT angiogram very carefully. You want to look at the vertebro-basilar system. And you want to rule out those kind of things. One more case. Okay, then just let's do this case and keep it last one. Stroke patients in 5 to 10% of cases can present with seizure. So stroke and seizure can happen, not very common, but it can create the confusion whether it was a stroke or seizure. And then it's hard to differentiate sometimes. There are some clues as a stroke physician we can determine. Obviously, history is very important when you do the field evaluation. What happened, whether there was any witness episode of seizure or limb jerking episode. Would like to know about that when we get the history. We want to know, okay, they had a stroke before, they are on any seizure medication, and then they can present with one-sided weakness, they can present with the gaze deviation. But there is some difference in gaze deviation in stroke and seizure, and I'll talk about it quickly here. So this patient, 67-year-old, witness to a generalized seizure-like activity noticed by facility staff. So EMS evaluated the patient. Patient was lethargic, not following command, had left gaze deviation, and left-sided arm and leg twitching, which resolved. But after that, patient had flaccid left paralysis. So if you see this CT scan, you are already seeing that patient had some kind of damage in the past on the right side, right hemisphere. These are the area hypodense area on the in the brain CT scan. So what are the clues here? So obviously witnessed seizure activity, that was number one. But when somebody has a seizure and if their gaze deviation is on one side and they have weakness also on the same side. So in this patient, left gaze deviation happened and patient had weakness on the left side. Seizure usually irritates the brain. It forces eyes to look away from the area of seizure. So if there is a stroke in the right side of the brain, eyes usually looks towards the side of the stroke. But if there is a seizure coming from that area, usually eyes gets deviated on the other side. So that was the clue in this patient, that left gaze deviation and left-sided weakness with seeing some area of damage on the right side. So this patient was not treated with thrombolytics. This is what I was talking about, the gaze deviation. So in the cortical lesion, if it is a stroke, then eyes would move towards the side of lesion, but in the seizure, eyes are going to be deviated on the other side. So that can give the clue. And then this patient was just treated with seizure medication, and it was a post-ictal phase, and then patient improved after some seizure treatment. Yeah, I can end there. Thank you.
Any questions for Dr. Kansara? No? Thank you so much. Appreciate that. Thank you. We are going to go to our last speaker. And Adrian's going to come over and introduce Robin.
Have you already got that stuff? Okay, so I would like to introduce Robin Miller. She is one of our nurse practitioners at St. Vincent. She also is faculty in the AGACNP program at OHSU, which I have no idea what all that stands for. And Robin's been involved in the AAHFN since 2015 and is currently serving as president. And she earned her BSN from CSU Fresno, her MSN from UCLA, and was awarded her DNP from University of Arizona. And she's here to talk about cardiogenic shock.
Okay, my goal is to keep you guys awake, both online and in the room. I promise I'll get everyone back on track so you guys will get out of here on time. As Adrian said, I'm Robin. I'm one of our NPs that works in the CICU and helped kind of develop our shock program here at St. V's, including some of the outreach that we've done with EMS. So I wanted to highlight some of the patients that are being seen and presenting first community side, and then also in the ED, and kind of walk you through what we call kind of our golden hour of cardiogenic shock. Okay, and by the, you guys will tell me if there's like things I need to stop. And if there's questions or if I say something, please like stop me in the moment. So big thing we talk about is out of hospital cardiac arrest. You guys all know the facts. Everyone knows the facts. We know it's actually it's a leading cause of death, and we know that we have unreported, but more than at least 350,000 cases annually. And of those that occur out of hospital, we know there's a 90% plus mortality. We do know, I don't know why there's a percentage and an and sign, of those who do make it into the hospital. So the 10%, of those who actually make it into the hospital, 25% will survive to discharge. So it's a pretty high mortality for these out-of-hospital cardiac arrests. And again, these are all comers. Can be from AMI, it can be from other differentiated times of shock. We do know that immediate bystander CPR, despite the quality, I know that we all have varying qualities of what we have seen, including very good to that's really cute that you think that finger is doing anything on the chest of that patient. We know that that can improve mortality and can improve, have upwards of 2 times impact on our survivability. The other piece that we know for out-of-hospital cardiac arrest is if you have a shockable rhythm, we have less mortality with a first rhythm being identified as a shockable rhythm than those who first present in PEA or asystole. Just basic facts when we talk about this. I know you've never seen a chain of survival as someone who works in the EMS or in the ED. But talking about why this is so important, especially in conjunction with cardiogenic shock diagnosis, is that the chain of survival really talks about early recognition, early help, early phenotyping, early CPR, so early management, and then early escalation of care, which actually really mimics what our cardiogenic shock pathway of care is as well. And so I thought this was really nice to actually talk about our cases in terms of the chain of survival, because they do actually overlap quite nicely. I also talked quickly, I apologize for that. Apparently someone told people that today, Friday the 13th, was when to have your out-of-hospital cardiac arrests and your shock. We've had like 6 shock calls, we've had 3 STEMIs. It's been insane. So I apologize. Hopefully I don't beep while I'm standing here. So when we talk about cardiogenic shock, everyone I think has seen this lovely spiral. I'm going to focus on AMI because that's going to be the one that we have that most impact on. So acute myocardial infarction shock. So when we talk about cardiogenic shock in relation to that, we know that we've had some kind of a myocardial insult that causes myocardial dysfunction. makes sense. Either pump no work because we are stunned, we are in VFVT, we have asystole PEA, maybe we actually did have an ischemic event like an AMI, now we've got a blown cord, ruptured tendon, some reason we don't have good pump function. And that pump function really then leads to the sequelae of what happens in cardiogenic shock. We have a drop in our cardiac output, normal compensatory mechanisms for all of us. We're going to vasoconstrict, we're going to jack our heart rates up, we're going to hold on to as much sodium as water as possible. And that's going to maintain some essence of a blood pressure, but it's going to mean your patient presents as tachycardic. They may not be hypotensive yet, but still may be tachycardic. That tachycardia, that vasoconstriction, that holding onto that sodium and that water causes a decrease in your coronary perfusion pressure. It decreases decreases your blood pressure. It further facilitates a decrease in cardiac output and further enhances your compensatory mechanisms, causes more vasoconstriction. It causes more retention of water and sodium. It causes more rhythm burden because of that retention and because of that upregulation of our sympathetic nervous system and our renin-angiotensin aldosterone system. That leads to elevation in our LV-EDP, our left ventricular end diastolic pressure, causes pulmonary congestion, where our patients have that flash pulmonary edema, horrible SATs in the field, poor SATs when they come into cath lab crashing, leads to progressive ischemia, and then obviously progressive cardiac dysfunction. So we know when we get into this first piece of this myocardial infarction and myocardial dysfunction, early identification then, early recognition, whether it be by the patient, whether it be by their caregivers in the community, whether it be by EMS seeing them in the community, or someone who presents to the ED with some of these symptoms, figuring out the phenotype and that it is cardiogenic shock early, we know will impact their mortality irrespective of AMI shock versus heart failure or other shock. And the reason for that is kind of this golden hour that we talk about in shock. The initial presentation for our patients who are malperfused is, by the way, anyone here in the ED? Okay, so patient, this is called a Tuesday. Well, it's really a Friday. Patient comes in with a blood pressure of 85/60 and a heart rate of 117. What's the first thing they get? 2 liters of IV fluids because they've mused. They also get blood cultures. They may also get ceftriaxone. So in this case, if our patients are hypotensive and tachycardic from a cardiac dysfunction issue, our patients in cardiogenic shock are hypoperfused, but they're hypoperfused with adequate intracardiac pressures. So you give that fluid and we continue spiraling down the circuit. Their blood pressure doesn't get better. Their heart rate doesn't change. In fact, their blood pressure may continue to drop because all we've done is increase congestion in a vasoconstricted and myocardial dysfunctional heart that's not pumping adequately, is not getting forward cardiac output. All we've done is increase the preload to the right side of the heart that's already struggling, especially when we talk about, say, our inferior MI patients who come in. And those are actually the cases I'm going to talk about today. So when we talk about the golden hour, recognizing that tachycardia is one of those first compensatory mechanisms, even in our cardiac patients, and a little bit of caution of not giving fluid potentially or high volumes of fluid as the first thing we do if we think the pump is the problem. So in this first hour, identifying our etiology, figuring out if it is shock, giving them whatever option they need. Is this someone who is an AMI patient? They're an out-of-hospital cardiac arrest, VTBF, they need a cath lab. We need to get them to an operating cath lab as quickly as possible. Is an out-of-hospital cardiac arrest not otherwise specified? I know we deal with a lot of overdose cardiac arrest, out-of-hospital cardiac arrest. So is this someone who needs to be treated differently? But the most important thing is if we think it's a primary cardiogenic shock is recognizing early, appropriately giving therapies and getting them to a center that can deal with their cardiogenic shock urgently versus delay. So putting it kind of all in the perspective, I know that was a lot of words. I'm also, by the way, I apologize. It's really hot. We don't call them hot flashes anymore. I've decided they're called power surges. And every woman in here better respect that because we are powerful. So putting it into perspective, we have 2 cases. Both are going to be patients who had AMI shock who presented, but both had pretty different courses of their care based solely kind of on time of presentation and identification of what was going on. So I thought it was great. This is a 54-year-old female. She was found down by her family. And by that, I mean her husband, which is obviously awful for anyone who was coming in. Only really known past medical history we had was diabetic. That also means that there may have been other things, but that was the only thing that was being treated. Was last seen normal by her husband the night before when she came home from a work trip. They activated EMS, AMR responded, and the initial rhythm was actually PEA on arrival. They did 21 minutes of CPR, ACLS, and did achieve ROSC. So you can see kind of initial strips upon or EMS presentation, in addition to kind of our post-ROSC ECG when she actually arrived to us. So when she, to the tertiary care center. So her post-ROSC EKG indicated she had a complete heart block, had ST elevations, obviously in inferior leads. We were dealing with AMI out of hospital arrest. So she was brought to the closest cath lab center. Unfortunately, I think as you guys all know, especially I'm a Providence person, so we do have sometimes constraints. Our closest CVL was the closest cath lab. However, we were not able to mobilize a cath lab team for a minimum of 30 minutes because we had an acute stroke in the lab that took up our room and our staff. So this person was brought to a hospital we weren't able to urgently activate. When we realized, and when the interventionalists realized that they were not going to be able to activate, they activated a cardiogenic shock team call. So cardiogenic shock teams are becoming incredibly common across the country. We have our own cardiogenic shock team here. That's to get our patients really early into a pathway of getting cardiology, cardiac surgery, an intensivist, and interventionalists if needed on the same call to say, what is the cause of this? What is the best management and where does this patient need to go? And those can be activated even pre-hospital. So our cardiogenic shock team was activated by our outside hospital, so Portland in this case, and decision was made to bring to St. V's. Unfortunately, you would think that 9.3 miles is not an insurmountable distance, but there are bridges and there are people and there's traffic. And as we all know, there's also oftentimes more emergency care needed than we have vehicles to get patients 9.x miles across the river. So from the time that the patient arrived at our outside hospital or at Portland to the time that the patient was able to arrive to St. V's, where we had a cath lab that was open and had a cardiogenic shock team that was ready to take that patient for advanced therapies, it was over a 2-hour delay. So 2 hours again, I probably could have put her on my back and gone. In the interim, because she has an inferior STEMI, starts to have continued clinical instability. She is having multiple VT and VF arrests. She achieves ROSC every single time, but every single hit she continues to have. Her lactate when she arrived at PPMC was just about 12 with a troponin greater than 25,000, which I measured at that point. When she arrived to us, she arrived on, we don't do weight-based things here, but she was on epi of 20. She was on norepi of 40. She had vaso running at 0.1. And she had a MAP of, I think, 44. Her lactate was above 13. And she was taken urgently to the cath lab and intubated there. So despite all of this, actually wasn't intubated prior to the transfer as well, because they regained ROSC every time she coded. So she was cold and mottled on presentation, obviously not mentating well. Because our cath lab and our cardiogenic shock team had been activated, a decision was made very quickly with cardiac surgery and with our cardiologists, with our interventionalists, that we need to proceed. She's young, she's 54 years old. We need to proceed with opening this culprit vessel. She's continuing to have VT and VF, but she's unstable and too sick for us to simply open her on the table. She would absolutely continue to code. So we actually placed her on VA ECMO support and then intervened on her lesion in the cath lab and brought her to the ICU. The reason I have this as a highlighted case, one, the VA ECMO, we don't really need to talk about that. Yay, we put her on cardiopulmonary bypass. But because of that delay, because of that initial spiral, she already presented as out of hospital cardiac arrest. She was technically alert when she arrived at the outside hospital. So when we talk about our cardiogenic shock stages, she was really kind of that stage C, had an intervention. She continued cycling and getting worse because we had that delay. So by the time she arrived, she was an absolute extremis. And that stage E reduces your survival pretty significantly because it's really hard to stop that spiral once it occurs. So she ended up coming, she was in DKA, which not surprising given the diabetes, likely would also contributed to this. She had a severe AKI requiring us to put her on renal replacement therapy. She had an acute liver injury that took well over 2 weeks to resolve, and then had a pretty impressive hypoxic respiratory failure that required multiple days of intubation, and including a failed extubation and reintubation. We talked about actually whether or not she needed traching. And so the question is, had we not had that initial delay, had we, when she arrived at her first hospital, could she have gone to cath lab then? Would she have been a safe candidate to get through PCI and not had some of these other sequelae? I'm happy to report she did. Sorry, it's the surgeon. I'm hanging up on him. Had we not had those delays, would we have been able to get her to cath lab without ECMO support? Would we have been able to delay some of these end organ dysfunctions? She did survive to discharge. She actually did make it. She was in the hospital for 17 days.
Something like that.
And then had to go to a rehab facility. She will eventually, hopefully, have a renal recovery, but has not yet had it. So this is now a woman who is non-dialysis dependent, who is dialysis dependent. Because of timing. So again, recognizing that spiral, recognizing that shock, EMS did exactly the right thing, but some of that in-hospital time, recognizing even when we have our limitations, what can actually happen to a patient. Now, I guess I kind of did this on this, so I'm just going to go through this again, but so kind of putting it into a different perspective, we have the other patient, also a woman. I don't mean it as a negative, but the reason I bring female cases up is we know females with cardiac disease die more often, don't get to the hospital more often, have more morbidity, because often they do not present or they aren't taken the same way as men. Plus we have atypical symptoms. So it's actually really important to kind of recognize that, but both these cases happen to be females. This one brought herself to the ED. She actually argued with her husband, who still wanted her to be at home. So she had acute onset chest pain at 6 a.m. Said, honey, got to go to the hospital. He begrudgingly brought her in. I'm actually not kidding. It was begrudging. And had a history of hypertension and hyperlipidemia. She was at an outside hospital or outside ED where she brought herself to, her closest one, had a VF arrest while waiting for EMS to arrive to transfer her, AMR to arrive to transfer her to St. V's. So she got 30 minutes of in-hospital witnessed CPR, was intubated, ROSC achieved, and because of the delay in timing, because she had arrested, she actually was given alteplase for her anterior or for her inferior STEMI, given that they didn't think she was going to be here in time for them to open up, and she had just had a VF arrest. So she did come in for a PCI, decided to put her first gas there, which is called. Also, feels like a Friday today. Not survivable, but this was her initial gas when coming in. They intubated her during her VF arrest at the ED appropriately. But by the time she arrived, she had such frank pulmonary edema from her persistent VF and her inferior MI. She also had some brand new MR. She was not oxygenating well. She had a PaO2, you can see, of 90, despite being on an FiO2 of 100%, and being on a PEEP, I believe, at that point of about 10. Her lactate was 8.6. We did a bedside ultrasound very quickly when she arrived in the cath lab, and she had biventricular dysfunction, pretty prominent RV dysfunction, not surprising given the inferior MI. So in this case, the interventionalist stopped, didn't touch the patient, and went, we need a shock call right now. This patient is incredibly ill, on levofed of 10, is not oxygenating, and is about to lay down on my table to have their vessel dealt with. This is not a safe patient to continue. And so a decision was made, and the surgeon the surgeon and the cardiologist actually went to the cath lab. A decision was made at the cath lab table, and she was cannulated for ECMO on the table. She was transferred to the CICU. She was weaned off of VA ECMO 3 days later. She was extubated successfully. She did not require renal replacement therapy. Her liver enzymes recovered within 5 days, and she left the hospital 12 days later. Absolutely. Oh, I have to remember to be here. Huh? Yes.
Okay.
Huh?
Yeah. Sorry.
Yes, 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 yes. Uh-huh.
We had a 3-year-old come to room like across the hall. So it was just an incredible moment. It's really good to hear that she's
Yeah.
doing well.
It was amazing. The work that was done, the quickness, the facileness of what was done for this patient was amazing. I still don't ever advocate for someone with chest pain to have their family member drive them in. Let me just say that right now, because they also went to a non-PCI capable hospital for that chest pain. Maybe not where I would have gone. But when we talk about this, 100%, the team, and actually I will say the team called it out even before the interventionalist did, in the cath lab suite, that this patient wasn't stable to continue going through the procedure. So early recognition this patient was going to spiral, was potentially going to get worse. Early recognition from that first hospital that this was an inferior STEMI and this patient needed to be at an outside, at a different hospital that was PCI capable. But more importantly, recognition that when things went south, they reacted quickly, they lysed her, and appropriately gave her some reperfusion to get her to a point where she was able to safely get to discharge. So kind of the general, I told you I get through it. I talk real fast, so I'm good for questions. Is that in general, and I didn't want a bunch of cases. I thought you guys might be falling asleep by the end. I can't sit for that long. You guys are heroes. Is we need to recognize shock early. We need to recognize shock in the pre-hospital context. We need to appropriately use our resources to get that patient where they need to go, because we do know that it directly impacts outcomes. We also need to know that while AMI shock is still a high preponderance of shock, we're seeing more and more other shock and really more heart failure shock. So patients who have known cardiac dysfunction, if that's part of their history, and they present or you're being called out and they are hypotensive or they're tachycardic, we actually have to have a high kind of pre-test probability that it's going to be a cardiac etiology and not a different etiology, and treat them that way until proven otherwise. I tell when we're in the ED constantly, we're like, it's okay if they get ceftriaxone. I'm better with a dose of ceftriaxone to meet our sepsis guidelines than I am 2 liters of fluid, but it's just most important to call a friend and recognize those signs and symptoms. In these 2 cases, recognizing the mechanical circulatory support for our cardiogenic shock population can absolutely be used. It needs to be practiced safely, and we have to use the right tools. But those tools can give us a bridge to an intervention or a bridge to recovery, and having that be actually the spotlight of our goal. Our goal is always to recover the patient, have the least amount of morbidity, the least amount of time down, the least amount of end organ malperfusion that we can to get that patient back to their prior quality of life. And then kind of ending thought is time absolutely matters. And we don't just talk about in hospital, but pre-hospital time. And then timing when they actually get to that facility. Just simply getting them to say to and someone which should be a tertiary center doesn't necessarily mean we're going to have the right steps taken, or that it's going to be recognized there, that we're going to have those opportunities or availabilities. So knowing kind of what our plan is at 60 minutes, 90 minutes, and 3 hours. And that was it. Questions?
Did anyone call the husband and tell him I told you so?
I think the wife may have taken care of that when she discharged. She had a honey-do list for the rest of 2025 was actually the name of the document. It was on her iPhone, and it was very long. It was very long. Told you everyone's asleep, but I got it done on time.
Yes, you did.
Thank you.
I'll use that power surge that you got. Speaking does that.
We have a wonderful, one of our intensivists whose wife is also apparently going through this. And on rounds, he just picks up his fan when one of us takes off our coat and fans us and puts it back down. Doesn't say a word. Doesn't say a word. Just does it. Awesome. He's amazing.
Well, thank you. I appreciate everyone joining. Again, apologize for any IT difficulties. I know I owe a few people that are like on public Wi-Fi apparently is the problem. Please fill out an evaluation, help us improve, and share things and ideas that you want to help us work on for next year.
Sorry.
Oh my goodness, Adrian. Yeah, you will get an email. Also, if this is a problem, you'll get an email this afternoon. And again, fill out the evaluation. Your certificate should automatically pop up at the end of that evaluation. Please email with any questions or concerns. And I appreciate everyone coming today. Thank you.
No, you're fired.
Faces over there like fighting for. I guess I should put small.